Welcome, everybody. It's the inaugural Community Wellness Partners Parkinson Symposium, a William and Rita Abraham Speaker Series event. My name is Allison Swartz, Parkinson's Program Director at Community Wellness Partners. We have reached an attendance of more than 200 people, which is a record attendance for our speaking engagements. So thank you all for joining us this morning. In front of you, you will see a QR code on a piece of paper, and it's got a little dinosaur on it. Please scan this code to lead you to a donation page for our Parkinson's programs. Any amount helps offset costs for people with Parkinson's to participate in our programs, which are also listed on flyers on our information table in the back. Before I announce today's presenters, I would like to introduce to you Dr. Jeremy Rutter, Chief Executive Officer for Community Wellness Partners. Welcome, Jeremy.
Thank you, Allison, and welcome. This is an amazing and wonderful turnout. This symposium brought to you, of course, by Community Wellness Partners, but more importantly, brought to you from the William Abraham family. And they've been great supporters of our programming. And in addition, the Bank of Utica supplements sponsorship. As Allison said, all of our programming is at little to no cost for our community members here. Just wanted to touch briefly, who is Community Wellness Partners? So we are a faith-based network of nonprofits. Most people know us either from Presbyterian in New Hartford, where we do on that campus our rock steady boxing and cycling programs, but also the Lutheran Home and the Lutheran campus over in Clinton, where we now have our therapy team based out of. We also have Presswood Glen, that's part of us. We also have a campus up in Oswego, the St. Luke campus. We additionally have an office up in Old Forge. Overall, we care for about 1,300 people every day, and we employ over 800 across central New York through Oswego, Herkimer, and Oneida counties. All that being said, if you know someone in Oneida County, they probably in some way or another have had their lives impacted by Community Wellness Partners, either as a loved one who's being cared for us or an employee. We have a great reach across central New York. We are, as I said, faith-based and mission-driven, and programs like this are amazing and reflective of our commitment to those people here in central New York. I want to again welcome you and thank you for this wonderful attendance. I think you're going to really enjoy this program. We have great speakers, and now I will let Allison introduce them. Thank you.
Thank you, Jeremy. I'm going to jump right into CWP's Parkinson's services. So once a person is diagnosed with Parkinson's disease by their primary care provider, they're then referred to a specialist. But as you know, to see a specialist may take 3 to 6 months, if not more. At Community Wellness Partners, we have a number of programs, free or at very little charge, in the meantime and in the long term. They are the following: Cycling with Parkinson's, which is cycling on a spin-style stationary bicycle that reduces the symptoms of Parkinson's. We launched this program last fall, and it's now in its second semester. LSVT Big and Loud are effective treatments for people in all stages of Parkinson's disease. Big helps people with Parkinson's improve mobility and daily living activities. Loud helps with speech and communication. Rock Steady Boxing, a non-contact boxing program, aims to improve the quality of life for people with Parkinson's disease. It's one of our hits. No pun intended. Nutrition for Parkinson's. We started this a couple of weeks ago. It's an 8-week program this spring that covers a healthy diet for people with Parkinson's disease. If you're not busy on Tuesdays at 11 a.m. through Memorial Day weekend, you can sign up with us if you are interested. Finally, each month we host a Parkinson's support group who meets on the third Tuesday of each month on our Lutheran campus. And I want to thank Rosemary Taylor. She could raise her hand. I know she's here. She's led this program for decades, and we will continue with the Parkinson's support group through 2026 and beyond. You may or may not know this, but we are, and when I say we, Community Wellness Partners is a certified Parkinson's disease care business. I used to say 4 of us at Community Wellness Partners completed a certification, but we're up to 6 who have completed the certification, where we had to gain all sorts of knowledge, and having passed a rigorous exam, we've earned the certification of Parkinson's disease care advocates. And Community Wellness Partners is a certified Parkinson's disease care business. Only 2 other organizations in New York State have earned such credentials. One of them is located in Long Island, and the other in the lower Hudson Valley. So we are the only Parkinson's disease care business certified in New York State in the upper 3/4 quadrant. I guess you could say the upper 3/4, I should say, of the whole entire state. So kudos to Community Wellness Partners for this. We have a great physical therapy team. We have a great rehab therapy team, Parkinson's supporters, and folks at Community Wellness Partners. And we have some numbers to to brag about. We've seen a 53% improvement in balance, 137% improvement in endurance, and 281% improvement in strength in people with Parkinson's, not us staff, but in you folks. That's where we've seen this improvement, who go through the LSVT BIG therapy program. Very impressive numbers by our rehab therapy team, who include Trever Gates and Julia Downing. You'll be hearing from them this evening. They're on the panel of speakers. Trever and Julia both have their doctorate in physical therapy, and they both specialize in LSVT BIG. They're also a part of the advocates that received the certification. Katie Conway, speech language therapist. Dee Hemeline and Kelly Bowden, who are in the back at our information table. They're physical therapist assistants. And then also in the back, I'd like to recognize Maureen Ferrugia, who's been in the fitness field for more than 40 years. She's the one that teaches the Rock Steady boxing. I want to also mention Pat Salzar. She's teaching our nutrition class, and she's also here. So thank you to you all. And if you haven't had time to visit the information table in the back, I urge you to do so. I tried to include many flyers on the tables, but there's also more information in the back. You'll also notice that we will have a question and answer session after each person that speaks, or after each segment. So there are slips in the middle of your table for you to write your questions down, and that way, when we're ready to ask questions or get those thoughts in your mind, get them down on paper, and we'll have somebody from our Parkinson's team and from CWP staff collect them, and they'll be asked and answered by the panelists up here at the podium. If we cannot get to your question today, we will make every effort to get those answers for you within the next couple of weeks via telephone call, email, or some other creative way. So we're going to start right off with our presenters. The first 2 will be Dr. Trever Gates and Dr. Julia Primps Downing. Trever is a graduate of Utica University's Doctoral of Physical Therapy program. His areas of interest include vestibular rehabilitation for vertigo, balance, and dizziness, ergonomics, and spinal rehabilitation. So not just Parkinson's, we have a team of all sorts of areas of expertise. Through the American Institute of Balance, Trever is certified in advanced vestibular rehabilitation, known as VR2. Trever also has experience working with orthopedic and neurological conditions and is certified in LSVT BIG. With more than a decade of physical therapy experience with short-term, long-term, and outpatient rehab patients, Dr. Julia Primps Downing's focus extends to managing pelvic pain, lower back pain, and addressing incontinence. She is adept at providing comprehensive care to individuals of all ages, fostering lifelong passion for exercise and movement. She is also in LSVT Big, and both Trevor and Julia are CPD advocates. So welcome, Trevor and Julia.
Good morning, everyone. Can everyone hear me okay? Okay, so thank you for the introduction, Allison. Again, this is Trevor and I'm Julia. We're the directors of outpatient rehabilitation here at Community Wellness Partners, and we specialize in Parkinson's disease. We wanted to talk today about not just getting a diagnosis of Parkinson's disease, but what you can actually do about it. Through physical therapy and exercise, we teach people how to live with Parkinson's and move as well as possible. Okay, a little bit more about our Parkinson's team at Community Wellness Partners. It's myself, Trevor, Dee, Kelly, and Katie. All of us specialize in Parkinson's disease, which is very important. If you go to a general orthopedic clinic, of course they're going to take you and they're going to treat you for your Parkinson's disease, but it's very rare that they're going to see more than maybe one Parkinson's patient every couple of months. At the old clinic that I used to work at, we took Parkinson's patients, but there was 10 of us. I saw one Parkinson's patient in the 4 years that I worked there. So it's very hard to work with someone that has Parkinson's if you don't see them in and out. There's so many different presentations of disease, and if you're going to a clinic where they don't specialize in it, you might not be getting the best bang for your buck. Here at Community Wellness Partners, we strive to spend an hour with each one of our Parkinson's patients one-on-one, which is also something that you're not going to see at other clinics. We use specific treatments to help override Parkinson's symptoms while also respecting the different variations of disease. Our goal is to help people move well and stay as active as possible for as long as possible. Okay, what we're going over today is what Parkinson's disease is. Since we're starting it off, I definitely want to define what Parkinson's is. Why physical therapy matters throughout the progression of disease. That's the beginning stages, the middle stages, and even at the end. What the research says about Parkinson's disease, physical therapy, and exercise. What LSVT Big is specifically, and our clinic statistics. I know Allison went over them, but we're going to get more specific on what those statistics actually mean. We also included a quick balance screen at the end so we can get a real idea of how our movement is. Okay, defining Parkinson's. So it's a progressive neurological condition that affects the central nervous system. Everyone kind of knows that it's about the motor symptoms, right? The tremor, the stiffness, the loss of balance and stability, changes in your automatic movement, like a lack of arm swing while moving, or loss of facial expressions. But in addition to these motor symptoms, there's also non-motor symptoms that can impact you. These include fatigue, sleep issues, anxiety or depression, changes in blood pressure or digestion. And in physical therapy, both the motor and non-motor symptoms come into play. And that's where a Parkinson's specialized therapist is going to do a little better job than just your run-of-the-mill physical therapist. Because we see these people in and out, and we know how to handle both the motor symptoms and the non-motor symptoms. All of the things that I just mentioned can lead to difficulty with your everyday life. Things like walking, getting dressed, your hobbies, staying active in the community, and even spending time with your family can become important if we don't do something to address these issues.
Good morning, everyone. So next, I'd like to discuss the Hoehn-Yahr classification scale for Parkinson's disease. So the Hoehn-Yahr scale is a 5-stage scale that discusses and grades motor symptoms associated with Parkinson's disease. It's important to recognize before we go over the scale, this is helpful in gauging our progression. However, every individual looks different regardless of what stage they're in. No two people with Parkinson's will look identical, even if they're both stage 2, stage 3, or whatever the stage may be. So let's go over each stage of the scale shortly. So stage 1 is defined as unilateral symptoms or symptoms only on one side of the body. This could be rigidity, this could be limited movement, this could be a tremor on one side of the body. As we get to stage 2 is where we begin to get symptoms bilaterally or on both sides of the body. Stage 3 is defined as symptoms that begin to impair our balance and our postural control. As we get to stage 4, we start to notice difficulty with our activities of daily living. This could be anything we do on a day-to-day basis. For example, getting in and out of bed, getting up and down from a chair, maybe brushing our teeth, shaving, whatever the case may be, any challenge with a daily activity. And stage 5 is the last stage of the Hoehn-Yahr scale, and it is defined as becoming more dependent on individuals around us, whether it's our family or a caregiver. It's when we really need someone to help us in our day-to-day life, and commonly at this stage we're reliant on assistive device such as a wheelchair. So it's very important in the Hoehn-Yahr scale to recognize that when we move forward in a stage, it is extremely difficult, or some may even say impossible, to go backwards in stage. All right, so within the stage we can help improve, but we can't go backwards in the stage. So what this means is prevention is key. We can prevent you from getting to the next stage, but once we're there, it's hard to do anything about it, or it's more difficult to bring us backwards in stage, all right? So what we can do with physical therapy and exercise and appropriate dosing of medication, of course, we can actually stall in one stage. It could be stage 1, anywhere to 4. We can stall in that stage for a decade or even 2 with appropriate exercise. So this goes to show why starting early is the most important. If we can stall in stage 1 for 10 to 20 years, that's amazing. That really holds off the whole progression of the disease. And the most effective way to do that is through appropriate exercise. So how does physical therapy help? So first, our goals with physical therapy, we want to improve gait and endurance, enhance our postural control and balance. We want to decrease our falling. We really want to improve rigidity and mobility. We want to improve our everyday life as much as we can. Whatever is limiting you, we tailor all of our exercises to each individual separately. So our goal, in summary, is really to keep an individual with Parkinson's as functional and independent for as long as possible. One study I like to reference, so in Parkinson's disease, the average decline in mobility year over year is 4 to 7% year over year, depending on which study you look at. 1 year, that might not sound like a big deal, but if we look at a 10-year period, that's roughly 40 to 70% decline over 10 years in functional mobility. However, with appropriate exercise dosing, studies show that that can be dropped to less than 1% year over year decline in mobility. Over a 10-year period, that's a drop to less than 10%. So going from 40 to 70% decline over a 10-year period to less than 10% is huge. That's a 75% or better improvement. So it just shows the importance of exercise. I like to look at the role of physical therapy with Parkinson's disease as training our body to use the signal, right? We need the medicine there to increase our signal, to increase the dopamine. But if our body doesn't know how to use this dopamine appropriately, it's not helpful to us. So physical therapy and exercise's role is to train our body how to use that dopamine most effectively. So we wanted to give you an idea of what physical therapy might look like and exercise as a whole might look like across each stage of Parkinson's disease. So in the early stages of Parkinson's, if we look back at the Hoehn-Yahr scale, this would be stages 1 and the beginning of stage 2. Our goal is really to emphasize independence and building good habits that you can realistically keep across your entire lifetime. This could be anything from rock steady boxing, this could be our pedaling class, this could be independent home exercise program, this could be independent LSVT big program, and hopefully it's all of them combined. One thing we also like to do in the early stage, in physical therapy, we like to get a baseline. We like to get a baseline of your balance, to get an idea of where your balance is today. We like to get an idea of your endurance and your strength. And that way, as we progress through the years, we can get an idea of, hey, your exercise program is working wonderfully, what you're doing is great. 3 years of doing this program, and we've done another checkup, and guess what? All of those numbers are the same. It looks wonderful. Or maybe it's not right for you. We have to increase it, we have to change it, we have to tether it to what you need more. So getting that baseline early on is very important so we can track the disease and see if the program is working right for you. As we get to the mid stages of Parkinson's, so this would be the end of stage 2 on that Hoehn-Yahr scale through the beginning of stage 4, really centering around stage 3. This is where we get more one-on-one and regular physical therapy as a rule. This is where we need help with our balance. We're really doing one-on-one balance exercises. We're doing regular LSVT big program. Maybe we get LSVT loud involved at this point if needed, depending on the individual. We still like to push independence with exercise as much as possible. And at this stage, we're really doing anything we can to keep your independence, to keep you as mobile for as long as possible, and to slow the disease progression as much as possible. And in the later stages of Parkinson's disease, our goal is to maintain safety, mobility, and to improve quality of life and maintain quality of life as high as we can. As we get to the later stage of Parkinson's, we're also doing a lot of family training at this stage. We're teaching your family what they can do to help you, what they can do to make your life better and make you more independent overall. One other big thing we work on throughout every stage of Parkinson's disease, we really want to focus on building confidence and participation in your normal life. Because of Parkinson's, we don't want that to be used as a reason not to go to your grandson or granddaughter's wedding, or not to go to the birthday party, or whatever the event might be. It's important to continue participating in all of those events. And so we really focus on that through every stage, keeping you involved in your normal daily life.
So a little bit more on why we want to start physical therapy early. Like Trever said, we want to establish baselines, but one of the biggest misconceptions is a lot of people think that you don't have to start physical therapy until your symptoms start impacting you. But really, we want you to come in as soon as you get diagnosed with Parkinson's, so we can point out those small, subtle changes so you can start working on them from day one. We may not notice the small changes on the one side of the body at the beginning stages, but Trever and I, Dee and Kelly, we pick up on that immediately. And we can teach you strategies through our physical therapy program on how to make those better. And for a lot of people at the beginning stages, we're not having you come 2, 3, 4 times a week. It might just be coming for an evaluation, getting that check-in, getting that objective information, and sending you home with a home exercise program so you can work on the things that we noticed. We also like to use research to back all of our treatments, and one of the things that we're going to talk about later in the presentation is how important doing a task over and over again can change our symptoms with Parkinson's. Also, doing exercise regularly is so important, and it shows that if you participate in a physical therapy or a structured exercise program regularly, for as little as 12 weeks, we can change the progression of the disease. So it is crucial to get the information from us. We can teach you things that you would never even know about, and then you're already a step ahead of Parkinson's. So I'm a little bit of a nerd. I love research. I always read research. Physical therapy is an applied science. So if you're doing the same treatments that you did as a physical therapist right out of school or 5 years ago, if you're still doing those today, you're probably missing things, right? So we have these clinical practice guidelines to help guide our treatments. It's like a roadmap using the most up-to-date evidence-based research to help us treat Parkinson's disease. Early last year, the Parkinson's-specific clinical practice guideline was updated, and there are some key changes that I want to go over. The first one is that exercise is a core treatment. I know we've been saying that throughout the presentation, but it's so important. That's why we have to keep saying it over and over again. Physical therapy should start early in the disease and continue throughout. Physical therapy and exercise is not just one and done. It's about changing your behavior, changing your habits, so you participate in lifelong exercise, and then come to physical therapy for those little check-ins, or maybe for a little bit of extra help working on your balance, whatever it might be. And then again, high intensity exercise and specific training on certain tests that you have trouble with is where the money is, where it's going to help the most. So the research shows that with Parkinson's disease, we want to have a strategy for movement short and long term so we can function as well as possible. Here are some of the key highlights of the clinical practice guideline. High intensity exercise is what creates meaningful change. And we see these changes not just in the motor symptoms like your walking, your balance, your stiffness, but we also see it in the non-motor symptoms. It can improve your sleep, it can improve your cognition, and it can improve your digestion. Strength and aerobic work are both important. You have to think of this as and, not or. You can't just do your aerobic work and ignore the strength training, and you can't just do strength training and ignore the aerobic work. We need both of these in order to function as well as possible. Balance and task-specific training are crucial. External cueing improves the freezing and the difficulty with gait. And behavioral change is the most important part because being consistent with all of these things is huge. Some examples of how we use the clinical practice guideline in the clinic include performing a series of physical therapy exercises in a circuit to drive intensity. So in the earlier stages of Parkinson's, this might look like every minute on the minute you're doing a medicine ball slam, going over your head down to the floor, right? Doing big movements. Then the next one might be walking back and forth, working on pivoting quickly but with good balance. Then the next one might be standing up and down from a chair as many times as possible, working on your transfers, working on your leg strength. And then lastly, you can do a medicine ball tossed, working on your reactive balance, working on your cardiovascular strength. That's really great for the people early on, but we also can do this with people in the mid stages or late stages. Maybe I'm doing an exercise or a balance task in standing where they're working on high intensity training there for them. Then I have them sit, but instead of just sitting and resting, maybe I'll do an easier seated exercise. So instead of just sitting, they're doing an active rest or an active recovery. We can push the intensity regardless of what stage of the disease it is. We just have to meet you where you're at, and then we progress little by little. I also want to mention that doing circuit training is great, right? You're going to get that in your rock steady boxing, you're going to get it in your cycling class, but with physical therapy, we're trained at looking at your heart rate, looking at your medications, these type of things. So when we're doing the circuit training, we're doing it safely, and we're teaching you what intensity is appropriate for you and your disease stage. Another example is using verbal cueing and visual demonstration to encourage larger amplitude movements while walking. You'll see me in the clinic and I'll be chasing someone down the hallway, yelling at them to swing their arm, move faster, but all of these things drives the change that we want to see. I might look a little crazy, but I swear it works. And then lastly, we can encourage people in a home exercise program to work on their own task-specific training, right? So I could send someone home and say, I hear that you have trouble pulling the chair out from the table, getting out from underneath the table and starting walking. You get tripped up on your walker, you get tripped up on the chair. If you practice that at home over and over again with big movements, big steps, then you're going to be ahead of things when you come back to physical therapy, because then instead of having to work on that in PT, we can work on things that are even more difficult. And then finally, when it comes to strength training, it's not about the pink dumbbells, right? That might be a starting point, 2 pounds, 3 pounds. But in clinic, I get people lifting 20-pound kettlebells, right? And doing a deadlift. What that's going to teach them is confidence, right? We're not broken, we're not small, we can lift 20 pounds off the floor, that's no big deal. And we can do it while maintaining our balance. And what that trains is your ability to shift your weight forward over your base of support. And what does that do? That makes it easier to stand up out of a chair. And that makes you more confident moving around.
So next we're going to discuss LSVT big therapy. which is Lee Silverman Voice Therapy Big. So it's a physical therapy specialty that we're all specialized in that is related to Parkinson's disease. So the principles of LSVT Big all follow the guidelines Julia just discussed, is designed with those guidelines in mind, all right? So it's talking about high intensity, high amplitude movements that are focused around your activities of daily living, or things you do every day. The theory behind LSVT Big is recalibration. That means we have the ability, an individual with Parkinson's has the ability to move big, to take those good steps, to have good balance. But the problem is they're interpreting it the wrong way. When they're taking the little steps, when their hands are in close to their body, their brain's saying, no, you're taking normal steps, you're doing big steps, you're doing it the right way. So the idea behind LSVT Big is to train the brain that this is the right way to move, these big steps, which in turn improves our balance, improves our confidence with activities. Like the guidelines, it focuses a lot, LSVT Big focuses a lot on repetition and task-specific training. You might come in and say, hey, I'm having the most difficulty getting up and down from a chair. We'll practice that over and over and over again until it becomes like second nature to you. And when you're at home, you have to get up and down from a chair, you know how to do it just like that. You hop up and down because you've already done it so many times. Like all exercise for Parkinson's disease, it's most effective when it started early and continued throughout the entire progression of Parkinson's. LSVT Big really should be trained in stage 1 of Parkinson's. If we have these particular movements, so it's 7 different exercises LSVT Big is, 7 particular exercises. If you know these 7 exercises from day 1 of stage 1, as the disease progresses, you already know how to retrain your body. You already are confident with these movements, and it'll help slow the progression. It'll help make you more confident and more functional throughout the entire disease progression of Parkinson's. So someone that comes in to physical therapy for LSVT Big, it's a 4-day-a-week, 1 hour per day session, appointment for 4 weeks. So this is an intense 16 sessions, more or less back to back, 1 hour each time. What this does is it really capitalizes on the high intensity of therapy for Parkinson's as is most effective for treating it. That doesn't mean everyone that comes to us does PT at that increment. Obviously not everyone can hold that. That's not always practical for everyone's day-to-day life. But that's the most effective way to improve your functional abilities if you have Parkinson's disease with this high-intensity program back to back to back. So I think we all know this by now, but exercise is medicine for Parkinson's disease. The World Health Organization recommends a minimum of 150 minutes per week of exercise for someone with Parkinson's disease, and that's of aerobic conditioning. That can be substituted with 75 minutes per week of high-intensity, vigorous exercise. This is in addition to a minimum of 2 days a week of strength training. So 2 days a week of strength training and a minimum 150 minutes per week of moderate intensity exercise. As we could probably assume, and as many of you are probably thinking, not that many people achieve this standard. But this is what we should go for, and this is what slows the disease progression of Parkinson's the most. So our goal with physical therapy, of course, is not just to give you exercises to make it sustainable. We're not here just to prescribe it and say, good luck, figure it out. No, we're here to make it sustainable to you and to make it effective in your life. When you start seeing the changes on your day-to-day basis, you realize this is helping, and that's where you really realize I have to capitalize on exercise going forward. So our goal is to prescribe safe and individualized exercise to each person. If I have 10 people with Parkinson's disease coming to see me, no 2 are going to be the same. Everyone's going to have exercises tethered to what they need and what they need to improve in their day-to-day life. Of course, the same principles apply behind them, but everyone has their own program tethered to them. At Community Wellness Partners, we really focus on one-on-one individualized therapy. It's not your traditional physical therapy you might go to and you're one of 3 patients getting seen by the physical therapist. No, it's one-on-one for that hour session, especially in Parkinson's disease. We're trying to use, our goal is to use behavioral changes to build exercise confidence for the rest of your life, not just short term. We're not trying to give you exercises for now, we're trying to give you a plan that you can follow forever. And so to give you an idea of the actual exercises we might do at each stage, early on, we mentioned this before, but it's good to reiterate it. Independent exercise, rock steady boxing, LSVT Big really should be started in this stage. Pedaling for Parkinson's is great at this stage. As we get to the mid stages, it's more of working on balance one-on-one. LSVT Big is certainly a huge part of the mid stages of Parkinson's disease. And in the later stages, we're recommending equipment, we're training your family, we're training you with equipment, and we're keeping you as independent and as functional for as long as possible.
Okay, so again, when we want to start physical therapy with Parkinson's, it's as soon as we get diagnosed, right? It's not something that you do once, it's something that we have throughout the disease progression, use us as help along the way to help teach you and help support your movement. Early in diagnosis, physical therapy becomes a powerful tool to, oops, I'm on the wrong slide. Oh, yeah. Sorry about that. Okay, so early in your Parkinson's diagnosis, it becomes a powerful tool to help understand your movement and take control of it. You're going to think of it as an ongoing process. You're going to bring awareness, like I said, to those small changes in your movement and mobility that you might not notice. It might help you appropriately dose your exercise intensity so you're doing enough to make a difference. I often notice when you see people at the gym, yeah, they're going 5 days a week, they're doing the cycle, they're doing the weights, right? But they use the same resistance on the bike or on the elliptical. They're using the same 10-pound dumbbell for 3 years. And our job is to show you what you're capable of, right? Help you understand what high intensity exercise is versus moderate intensity exercise, so on and so forth, right? Because if you're going to the gym and just going through the motions, it's better than nothing, but why not go and spend that 30 minutes, 45 minutes, an hour doing something that's going to make a meaningful change in your health and wellness. I also like to think of myself more as a coach when it comes to Parkinson's disease, right? We're here to support you and challenge you and have you strive for the most excellent movement that you can do and how healthy you can become. Participating in physical therapy allows you to stay ahead of your symptoms, not just react to them. Okay, Allison already went over these, but they're so impressive and I want to get a little bit more into what exactly these random statistics mean. So for the past 3 years, since we've been giving LSVT big therapy to people, so anyone that's participated in the 16 sessions, the 4 weeks, 4 times a week, 1 hour a day, we've tracked their metrics from evaluation to discharge. And these are some of the things that we've seen. We've seen a 53% improvement in the Timed Up and Go test. This is a test that assesses your abilities to initiate your walking after getting up from a chair, your ability to negotiate a turn, and maintain your dynamic balance. So people come in, sometimes they need a walker, they need a cane. Some people, they need a wheelchair, right? And then 16 sessions after, the person in the wheelchair is able to do this test with a walker. The person with the cane is able to do it without a cane. The person with the walker is able to do it with a cane. So we're making it so you can decrease the amount of assistance you need with your movement, your balance, and walking to make it easier for you to go, like Trever said, to your son or daughter's wedding out in the community. Because who wants to bring a wheelchair out if you can just use a walker? How much easier is that? The next improvement, this 137% improvement in the 6-minute walk test, or our walking ability. This test, we walk for 6 minutes straight in the clinic, right? Whether that's using your walker, not using a device, using a cane. Maybe it's using a walker, but we have to follow you with the wheelchair because you can't get that far, right? We look at that and we assess what your gait looks like, the quality of it, how your arms move, how big of steps you're taking. And we also assess your endurance. Can you only walk about 100 feet and then you need to rest? Do our Parkinson's symptoms get worse after 200, 300 feet? Then we take that information and use it to tailor our LSVT program and the physical therapy that comes with it. And then finally, the biggest improvement, my favorite test, leg strength, right? The 281% improvement in the 30-second chair rise test. What this test assesses is how many times you can stand up and down out of a chair in 30 seconds. You're not allowed to use your arms, you just have to use your legs. So this gives us an idea of your leg strength, your standing balance, and your leg endurance. Many people, when they start LSVT big, can't even get up out of the chair without using their arms. Then by the end, they're able to do 10, 15, 20 in a row without stopping. It's simply amazing, right? And this test, it's the biggest change for us, but I think it's most meaningful, right? We keep talking about movement and exercise, but if it's hard for you to just get up out of your recliner, get up off your couch, you're not gonna wanna leave the house. You're not gonna wanna do things for yourself. So this ability to get up out of a chair is like day one, most important part, and it's gonna follow you throughout the disease progression. If you can stay mobile and keep that ability to stand up out of a chair without your arms, you're gonna go so much further.
So key takeaways. Physical therapy, I think we all know this now, but physical therapy is strongly recommended regardless of which stage you're in with Parkinson's disease. Earlier is better, of course. The earlier we start, prevention is key with Parkinson's. It's much easier to slow the progression than it is to go backwards. Programs like LSVT Big match recommendations set forth by research. And it's important to recognize that Community Wellness Partners offers help in every one of these stages. As we talked about, Rock Steady Boxing early, we have pedaling for Parkinson's, we have nutrition classes, we have, if we get to the point we need, if we get to the point where we need help at home, we even offer home health aides. We have help in every stage of Parkinson's disease, and that's important to recognize. So lastly, what we wanted to do was a little test or a little idea to give you an idea of what your session might look like and what we test with someone with Parkinson's. So I think Julia is going to demonstrate this for us. So just two little tests we do. We do lots and lots of different outcome measures, but these are just too easy to demonstrate today. So one of the most important ones Julia will be demonstrating is standing up and down from a chair with no hands. It does not matter what your age is or what your comorbidities are. You should be able to get up and down from a chair relatively easy without your hands. If we do this for 30 seconds straight, our goal is to get 15 of these in 30 seconds. All right? Another outcome measure we commonly use is a tandem stance. So standing heel to toe. Once again, regardless of which...
It's really hard.
So she's going to stand one foot in front of the other, regardless of which stage you're in with Parkinson's, regardless of how old you are, what your comorbidities may be. You should be able to stand for 30 seconds heel to toe. That's always our goal. That's what good balance is defined as, standing like that.
That's everything.
Absolutely. And we wanted to quickly mention, in our outpatient therapy department, we do not just treat Parkinson's disease, and of course individuals with Parkinson's don't just have Parkinson's, there's other comorbidities out there. So we have occupational therapy, we have speech therapy, we treat balance and fall prevention, as I think we all know by now. I specialize in vertigo and vestibular therapy for those who are dizzy. We treat back and neck pain, post-stroke, pelvic floor. Julia specializes in pelvic floor therapy, including bowel and bladder incontinence, which is really important to know there is something you can do about that. And of course, anyone post-surgically we work with, whether it's a joint replacement, rotator cuff repair, ligamentous reconstruction, and post-amputation therapy. Before we get to questions, I wanted to bring up the most common question we get. All right, so I want to start physical therapy. What do I do? What do I have to do? So we have two great resources, Allison being one. You can always call Allison if she can walk you through that whole process, or call our office too, which our cards are back there and we have her number, and we'll help walk you through that process. It's very simple. Get a prescription from your doctor. I've never had a doctor before say, oh, you can't get physical therapy. No, they're very happy when you want physical therapy. They recognize the importance of it. And then we get you scheduled for an appointment. Another benefit, and the only way to really know the answer to that question, is by getting your outcome measures or your tests early on, and then we can track, is the program we gave you effective? If we know this is where your balance, your strength, and your gait is early on, we have those numbers, and then as you work on your own with Parkinson's disease, we can gauge, is this working for you, or do we have to change something up to do the formal therapy? I like this question. This is good. So, can we train neurologists in our area to refer to LSVT and know more about it? Someone's trying to get me in trouble here. So, in all actuality, that is one of our goals as Community Wellness Partners, and Allison has been going around to primary care and neurologist offices and doing in-services for them on not just our services, but the importance of what we do. So, it's funny, but it's also good. It's very true.
The next question here is, what therapy can be done for stage 5 patients? And there's plenty we can do. I currently work with a gentleman that is stage 5 of the disease. And he comes twice a week. I have him on a maintenance program. So initially I had him on what's called restorative therapy, where I got him to a point where I improved as much as I could. Now I'm working on maintaining what we've improved, right? So he comes 2 times a week. We work on his transfers. At home, he uses assistance for transferring. It's called a Sarah Steady, so it helps you stand up and down so your caregiver isn't breaking their back doing it. So in the clinic, he works on standing up and down with my assistance. And then also, I walk with him. Even though he's a wheelchair user at this point, we still work on walking, so we can work on that reciprocal motion, which is going to help with rigidity and stiffness. And just imagine if you were to be sitting in a wheelchair all day, how uncomfortable that could be on your back and your legs. So this 2 times a week for him is just so important.
So how do we get specific PT for Parkinson's when we don't live in the area? So LSVT Big has a website, and you can look up any certified provider in your area or whatever the area might be. That would be my recommendation with that. Or we certainly do have people. We have one person that drives to us from about an hour and 20 minutes away, and actually the individual Julia was just talking about drives from about an hour and a half away, 2 days a week for it, because they recognize the importance and value of it.
And to add, coming to outpatient physical therapy, the 2 times a week, whatever it might be, in those later stages, just getting out of the house, in and out of the car, into the clinic is so important. And then the next question here, someone said, insurance question mark, transportation question mark. So, okay, Trevor has that one too. So, we take most insurances, and our secretary, Maria, she's amazing at making sure that you guys have the appropriate coverage for physical therapy. Even though we offer these specialized Parkinson's programs, when it comes to insurance, we're just billing for physical therapy. It's not something special that you have to add to your insurance. So really, as long as you have insurance, we'll be able to cover you. And then transportation, that's a good question. Hopefully in the future, maybe we can start having some transportation, but that all depends on funding and things like that.
One thing to add to the insurance too. So most individuals with Parkinson's are on Medicare. Medicare covers physical therapy up to the physical therapist's discretion. So as long as we deem it medically necessary, we can continue physical therapy. They cover it at 80%, so 20% falls on the individual, just to give you some idea. But most people have another insurance that goes with it. Most people don't just have Medicare on its own. So that'd be an individualized basis. So we have the question, do you know about physiatrists? My doctor directed me to find one. So a physiatrist is a rehab doctor. To tell you the truth, you could, yeah. Outpatient? Okay. I don't know about any, I've never had anyone specifically with Parkinson's go to a physiatrist. As a rule, you have your neurologist, and they refer you to physical therapy.
I used to work with a physiatrist out in Rome. They seem to be more orthopedic in nature, right? Your bones, your joints. I think as long as you have a good neurologist, a good primary care doctor, if you want to use a physiatrist as a primary or an additional, you can, but you know, there's nothing super special whether it's a physiatrist versus an MD, right? You just want to find someone that understands what you're going through with Parkinson's. And then my question here is, are there local neurologists that are good partners with our rehab team, with meds and knowledge of, you know, how physical therapy, meds, stuff like that? that's another thing that's why we're doing these speaker series and these outreaches, right? We want to find a neurologist that's going to work right with us. I would love to be able to say, yes, so-and-so is great, you can go to them, but just like with our primary care issues in the area, neurology, it's hard to get into a specialist, and honestly, it's hard to find ones that specialize in Parkinson's. I'm so happy that we have over 200 people here. That way people can talk and say, hey, I have a good neurologist here, or I have a good neurologist there, and maybe we can find someone that then Allison can go reach out to, so we have a better partnership in the community. It's so important to have different people that know what's going on in the Parkinson's world, so then we can all work as a team.
So how long is the wait list to get in for an appointment for PT for someone with Parkinson's? So that's a great question. As a rule, roughly a week out. We can get someone in within a week is usually our goal. That's what we always strive to do. Of course, it waxes and wanes based on how many people we have calling at that particular time. But within a week is usually our standard.
I like this one. How does having surgery, an injury, another setback affect physical therapy for Parkinson's? How can Parkinson's patients stay active? Trever and I, by trade, before we started working at Community Wellness Partners, we were orthopedic specialists before anything else. Your low back pain, your knee pain, your athletes, everything like that. So we're fully equipped to not only work with Parkinson's, but to work with someone who has chronic low back pain, issues with their shoulders, whatever it might be, a rotator cuff repair, all these things we can do in addition to helping you with Parkinson's. And we can do both in the same session, right? Depending on which one might be impacting you more, maybe we'd spend 45 minutes doing your shoulder, and then the last 15 we work on Parkinson's, or vice versa. There's so many things we can do in an hour session, and especially when you're one-on-one, we don't have to worry about sharing our time with another patient. You get us for that full 45 minutes to an hour.
So talk about LSVT Loud program. Yeah, that's a great question. I'd love to talk more about that. So LSVT Loud, we have a speech therapist who specializes in LSVT Loud. It is similar to LSVT Big in that it's 4 days a week, 1 hour sessions for 4 weeks. As many of us know, with Parkinson's disease, our voice tends to quiet, become softer over time. LSVT Loud focuses on projecting your voice and being able to hold a conversation with your loved ones without having to worry about, what'd you say, what was that? The entire time.
What to expect for Parkinson's with dementia? I've had a few of these patients where we have to deal with not only the motor symptoms of Parkinson's, but like I mentioned at the beginning of our presentation, the non-motor symptoms like dementia. In addition to working with patients with Parkinson's plus dementia, I also have experience working in a long-term care setting and a short-term rehab setting, where you learn different nuances of how to work with people with different cognitive issues. So, for example, if I were to work with someone with dementia, maybe it would mean going a little slower, explaining things every session, even if we do the same thing over and over again. People with dementia, they like to come back in and kind of re-ground themselves, and I remind them that we're doing X, Y, Z today, and give them more cues, so then they feel more comfortable and they don't have to be expected to remember what we did last session or a week ago.
So how to improve motivation with clients who are depressed, fatigued, and unmotivated? That's the million-dollar question. So the way I look at it is we have to get to what makes someone tick. Whatever you are looking to gain back in life, we need to tether everything to that. And when you see we can make these meaningful improvements day to day, and we can improve what you specifically want to improve, that's what makes someone motivated. If you're there doing generalized exercise and you don't know why you're doing it, no one's going to want to do that. No one's going to want to do it regularly. But if you can recognize that doing this exercise, doing this treatment is going to improve my ability to go visit my granddaughter, then that's absolutely wonderful. And that will get someone more motivated.
If you already completed a physical therapy program, can you also start this program with your insurance? Yes, of course. I kind of talked in the beginning, not to badmouth other clinics, right? But if you've had experience with Parkinson's disease and physical therapy, and you didn't feel like you got much out of the physical therapy, it might be worth a shot to go try another clinic. Or if you're currently at a clinic and getting physical therapy, advocate for yourself. Tell them, hey, listen, I hear that you're supposed to be treating me one-on-one. You're supposed to be doing high-intensity exercise. Advocate for yourself and tell them that you know about this disease and you expect the proper care. Like we said in the slides, it's not one and done with physical therapy. Just because you did physical therapy once and maybe you didn't like it, or maybe you got something out of it, but it's been 3 months, come back and try it again so we can see how you're moving, get objective information, and help you move the best that you can for as long as possible. This one also is asking if they could do our program if they're attending aquatic therapy. And as long as you're attending aquatic therapy for something like osteoarthritis, knee pain, nothing to do with Parkinson's, you can do them together, but we have to make sure that we're not duplicating services, if that makes sense.
So what changes does Parkinson's have on blood pressure? So it's an interesting answer. We see both directions. Depending on your medications, we have people that have sudden bouts of very high blood pressure and a lot of people that have bouts of low blood pressure. Something we certainly monitor throughout our physical therapy session to make sure exercises are safe and effective for that individual.
Also to note on blood pressure too, when you exercise and you do it consistently, your body then acclimates to that movement, right? Sometimes our blood pressure drops because we're not active enough, and then you're getting up out of a chair, walking around, or you're coming to the physical therapy clinic, and your body doesn't know what to do, so your blood pressure plummets. So if you're consistent with coming to physical therapy where we can monitor your symptoms and get you exercising, then you're gonna be able to do more, and ideally, as long as your medications are titrated appropriately, the drop in blood pressure or the raise in blood pressure won't affect you as much. I just have first slide that one's picture.
You want to flip through
Do you
lines
want
for
to
the
get
last
to the
question?
last one?
Yeah. So are the speaker's notes available? If you're referencing the PowerPoint, yeah, we don't have any problem giving you a PDF version of the PowerPoint. The notes from what we were talking about, no one will be able to interpret that.
One more. The other one? This one?
Nope, keep going. Keep going.
One in your arm?
This one? Go for it.
And I think that's time, right, Allison?
Yes.
All right. Thank you, everyone.
Allison Bowers is a registered dietitian specializing in medical nutrition therapy for individuals living with neurodegenerative disorders. With extensive experience supporting patients diagnosed with ALS, Huntington's disease, Parkinson's disease, multiple sclerosis, and related neurological conditions, Allison provides evidence-based nutrition recommendations tailored to each stage of disease progression while also supporting caregivers. She holds a master's in public health from Boston University with subspecializations in social behavior science and health communication. She is currently the campus dietitian for Colgate University, where she oversees nutrition programs for over 22 Division I teams and is an integral part of the campus's eating disorder management team. She understands the powerful connection between nutrition and the brain, and with a holistic approach, Allison helps with individuals optimize performance and cognition by focusing on sustained behavioral changes. Welcome, Allison Bowers.
Good morning. That was fantastic. I don't know what I learned so much. My fun fact about myself is that my dad is actually a physical therapist and my mom is an occupational therapist. So I always have such a deep appreciation with that team approach and the work that's being done in those clinics. So yes, today we are talking quite a bit about nutrition. Let's see, okay, so it is this one. Yes, okay. I always like to start my presentations with just sort of a quick overview, a nutrition 101. I never want to assume that I'm walking into a room and people know exactly what I'm talking about. So I like to get us all on the same page so that when I'm using terms like protein and carbohydrate, we all kind of have an idea of what that actually means. So we have these three major macronutrients. There's a few more, but these are sort of the big three. And this is really, this is what our diet is going to be hopefully quite abundant in. So carbohydrate, body's main source of energy, particularly the brain. Our body does not use protein or fat very efficiently when it comes to energy. It really needs that good glucose from carbohydrate. So the body breaks it down into various types of sugar. It also contains fiber. I'm going to do, again, a much deeper dive into what that actually means a little bit later. But it's typically found in grains, fruits, vegetables, dairy. So meat, for example, is not really going to have much carbohydrate in it. So really those grains, fruits, veggies, plants. Protein, building blocks of the body's tissue, including muscle, skin, hair, nails, right? We just learned a whole bunch about muscle. And one of the interesting things about protein is that it strengthens muscle after that muscle has already been worked. So there's a lot of misconceptions and then there's a lot of misinformation out there about high protein diets are really going to help with my muscle. And in a way that is true. However, if I am not keeping active, if I am not participating in any sort of physical therapy program, if I am just sort of sitting all day and eating a high protein diet, protein cannot just like spontaneously create new muscle. So that muscle has to be worked. It has to be pretty much worked to exhaustion. Those muscle fibers sort of tear down a little bit. The body does not like it when things inside of us are torn down, so it's going to be very quick to try to fix those fibers, strengthen them. Hopefully each time we go to physical therapy, those muscle fibers are getting a little bit bigger, a little bit stronger. Protein is sort of like the Band-Aid within the body that can help with that. And of course, I will get a lot. I will be speaking quite a bit on protein later because I know that that's obviously a hot topic in managing Parkinson's. Timing is essential. Again, so after that muscle's been worked, there's often a like 15 to 20-ish minute window after a really hard exercise session or something where that muscle's been worked, where the cells are primed for repair, right? Like those muscles are super inflamed and our body really wants to fix that, hopefully prevent some soreness. So having a good source of protein right after a good workout, after your boxing, after your cycling, after your physical therapy can really help with that. So again, found in meat, fish, seafood, beans, legumes, soy products. You can get it supplementally. The body typically is going to absorb protein much better from food, much more efficiently from food. So a word on supplements, and I will get into this again a little bit more, but supplements really should just be supplementing, right? They should be filling a void, a gap that is found in the diet. So if you have the option of food and you can get everything you need from food, most people don't need supplements, but that would be done sort of on an individual basis. So with protein supplements, again, it can be helpful. If you are somebody who's traveling an hour and 20 minutes for physical therapy, maybe having a protein shake in the car on the way home is not a terrible idea, right? But if you have the option of going home and having a nice piece of chicken or cottage cheese or something like that, that would be a much better option for you. And then the third one is fat. So this provides long-lasting energy. It aids in absorption of fat-soluble vitamins. So we have 4 vitamins in our body that we need, and those live in our fat cells. Particularly vitamin D is a really big one, especially in this area. We tend to be indoors all winter long. We don't get a lot of sunlight, and so our vitamin D levels, just sort of as a population in colder climates, tends to be a little bit lower. So we do need a certain amount of fat in our diet to actually help keep those vitamins at an abundant level. And then it maintains healthy skin, protects organs, and protects the brain. And then we have our micronutrients, right? So these are the vitamins and minerals. These are things like iron and magnesium, Sodium is a big one, so I know we had just been talking a little bit about blood pressure, right? And so sodium can really affect our blood pressure, where if we have low blood pressure, higher sodium can help. If we've got high blood pressure, so lower sodium diets can sort of help manage that. Required for health growth, disease prevention, so full of antioxidants, helping with immunity. And then they're actually absorbed better, again, from food than from supplements. So again, a general multivitamin typically isn't going to hurt anybody, but anything beyond that often does. It is beneficial to get some sort of nutrition assessment just to see if you do need supplements. I mean, I know that it doesn't take an advanced degree for me to stand up here and say that the supplement industry is a multi-billion-dollar industry, and so I think that there is it does warrant a deeper conversation when it comes to individual needs for that. Alrighty, so now we have those major terms out of the way. Can diet help with Parkinson's? I mean, the short answer is yes, right? I probably wouldn't be up here if the answer was no. That would be a silly waste of everybody's time. So the big pillars, right? We want to prevent malnutrition. We want to manage inflammation, right? But what does that actually mean? That sounds great. Keeping up with therapy, right? Preventing that muscle loss or building new muscle, right? When we're lifting those 20-pound dumbbells off the floor and our muscles are getting really tired, we want to make sure that as those muscles are being torn down, they're being re-repaired, that protein is getting in, and that we're really preventing malnutrition, and that we're really growing that new muscle. Managing inflammation. So joints particularly can become very inflamed, right? We're talking about stiffness, right? Or we're talking about involuntary movement. Now when I talk about inflammation, not to get into the weeds, not to get too sciencey, we are talking more like at the cellular level. So it's not like, oh, look, my knee is inflamed, let me eat some eggs which have some heart healthy fats, and now the inflammation is going to go down, right? But we're talking about keeping those cells really functioning at their peak capacity. Promote gut and brain health and maximize the gut-brain connection. So I have a great slide later where there's this big circle, right? And we've got nutrients that are developed, that are promoted, that are produced in our brain. We've got things that are produced in our gut, and they get sent back and forth on this little highway all day long, over and over. So we need a healthy brain to have a healthy gut. We need a healthy gut to have a healthy brain. And then, of course, improve or maintain nutrition, maintain nutrition quality of life. So that's thinking about things like going to weddings, going out to dinner. Can I still eat my favorite foods comfortably, right? How am I managing my favorite foods? Do I need to time things differently throughout my day, right? So these are all sort of the major considerations. So what diet is best? I think one thing that's really, really important is that nutrition here is supportive. It is not curative. Right, so when we're looking at nutrition, we're looking at it through the lens of helping to manage symptoms, helping to support other pieces of the picture, such as going to physical therapy, right? We want to make sure that we are feeding our body in a way where we can keep up with that. For the caregivers here, right, we need to make sure that you are also feeding yourself so that you can continue to keep yourself healthy and function at your maximum capacity. So research has shown over and over and over again that a Mediterranean style diet really does help reduce that inflammation, helps with blood pressure, helps with all day steady energy control, right? One of the things that we want to avoid for anybody, right, Parkinson's or not, is we don't want these big peaks and valleys of energy, right? We don't want to eat and then we feel good and then we crash. And then a little time goes by and we eat and then we feel good and then we crash, right? So with this plant forward style diet, we're going to get nice steady energy all day long with these little blips. And so what does plant forward mean, right? It is not a vegetarian diet. It could be. Certainly, there's room for that. It just means that you really want an abundance of plant-based foods. It does not mean just eating salads all day long, right? I am certainly not the rice cake and carrot stick police up here. But when you are looking at your meals, you're planning your meals, you're planning your snacks, you want them to sort of abundantly come from the earth as much as possible, and that includes all food groups. So more fish and poultry, a little bit lower in red meat. One of the big things with red meat is that it's more the red meat that's going to be higher in saturated fat. So if we're looking at like beef, for example, right, looking more towards like a sirloin, or if you're buying the ground beef, maybe it's a 90%, a 93% lean. And then if it starts to get a little dry, you're gonna add some heart healthy fats such as olive oil, as opposed to buying the higher fat cuts of, say, marbled meat, right? Because those just do lead to a little bit more inflammation. Emphasis on whole grains, oats, brown rice, potatoes and corn actually count as a whole grain, whole wheat breads, cereals. And so when we think about a grain, right, when we think about how wheat grain grows out of the ground, it's got a couple different layers to it, right? If you were to look at it under a microscope, it's got a couple different layers. All of those layers have different nutrients in them, right? So we've got some protein in there, there's some B vitamins, there's some fiber. As that grain sort of goes on its journey through the manufacturing process, sometimes those layers start to get stripped away. We lose some of the fiber, we lose some of the protein, we lose some of those B vitamins. Sometimes it's added back in. So the case of, like, if you ever see enriched flour on a food label, it means that they've added most of the B vitamins back in at some point during the processing. But if a grain remains sort of unprocessed, if you will, it stays whole. You get all the B vitamins, you get the protein, you get all the good stuff. So that is where you get things like oats and brown rice, for example, as opposed to, like your white breads and white rolls. And then there's emphasis on heart healthy fats. So salmon, avocado, olives, olive oil, nuts, seeds, things like hummus. And then lower in added sugar and low nutrient foods. I just sort of threw soda and sort of processed baked goods up there. If anybody knows me, I am an all foods fit dietitian. Let me put that out there in lights. I promise every food fits into the diet all the time. The big thing is the balance, right? I promise if anybody saw me last night, I was at home on my couch eating pizza, right? I work in a college campus, I work in a dining hall, I have a soft serve ice cream cone every day after lunch. And I'm also working hard to get my 150 minutes of physical activity every week, right? And when I have that ice cream cone, it's typically after I've had a green salad with maybe some chicken or tofu and some sweet potato, right? So again, it is about that balance. It's plant forward with sort of some of our favorite foods kind of sprinkled in there as needed. So some of the common nutrition challenges, I sort of just chose the big ones that I typically see. I could probably give I could probably teach an entire course, a semester-long course on nutrition challenges. Loss of appetite. I think that's probably one of the biggest ones that I see. Sometimes that's medication related. Sometimes that's nervous system related. Sometimes that's hormonal related, right? So our appetite is controlled by this network of hormones and nerve signals. And so sometimes if those start to be affected, we start to lose our appetite. Also, if our activity starts to get low, right? Like if we were once very active and now we're having some mobility challenges, appetite can certainly be affected by that. Depression, anxiety, all of those things can certainly affect our appetite. So focusing on higher calorie meals and snacks, right? So that's where we're gonna add things in like whole milk, right? And things like olive oil, avocado, right? We're gonna focus particularly on some of those heart healthy fats. Fats are very dense. They're more than twice as dense as carbohydrate and protein. So often that's why the portion size tends to be a little bit smaller, right? There's a reason why the portion of lettuce is, a cup or 2 cups, and the portion of peanut butter is like 2 tablespoons. Unfortunately, I don't make the rules. If I did, it would be opposite. But when we're looking at those higher calorie meals and snacks, right, really figuring out where can I add things in for a good bang for my buck, right? Seeds are great as long as swallowing is not a concern and you can have seeds. Seeds are great adding things like chia seeds, flax seeds, because they don't necessarily increase the volume of food, right? One thing when somebody has low appetite, the last thing you want to do is say, well, we need to increase what you're eating, so we'll just give you 2 dinners or 2 lunches or 2 peanut butter and jellies. That doesn't always work, and that can often become very overwhelming. But sometimes sprinkling in some chia seeds or some flax seeds into something like a yogurt or a shake or a smoothie can go a long way because it doesn't increase that volume, it just increases the nutrition and the caloric content. Sometimes smaller frequent meals, right? Maybe having, something solid 5 or 6 times a day makes more sense. Maybe it's less overwhelming than having to sit down to 3 big balanced meals per day. I do this with my athletes all the time. Beginning the meal with the highest calorie item, right? Dessert first, why not, right? If that's the thing that's gonna stimulate your appetite, I'm here for it. Or including high-calorie nutrition shakes as needed. Yes, you can say, you can go home now and be like, you know what, the dietitian told me I have to have dessert first. So that's what you said, sorry, gonna follow the rules. Difficulty swallowing, right, also known as dysphagia. So speech-language pathology, occupational therapy should certainly be involved here. Dietitians obviously cannot do things like swallow valves, but this is where a team approach becomes so important, right? That if somebody comes to me and they can only have soft foods, or they're on thickened liquids and dehydration's becoming a problem, right? This is definitely something where you would need sort of multiple hands in that. Again, smaller frequent meals can help with that. If it takes a lot of work to swallow, if swallowing is scary, if it's uncomfortable. This also goes for chewing and self-feeding difficulties, right? If it takes a lot more effort, then maybe doing it just for a shorter amount of time, more often with some breaks in between, makes more sense than trying to sit at the table for 20 minutes or 30 minutes or longer trying to get that food down. And then again, including high-calorie shakes as needed, as able. And then prioritizing hydration. So oftentimes with difficulty swallowing, sometimes thickened liquids are involved. You could certainly have some difficulty swallowing and still, have thin liquids. But definitely that can certainly lead, it increases risk for dehydration. Mobility can also increase risk for dehydration, right? If it is really difficult to get up and maneuver your way into the bathroom, or you don't know where the bathroom is, or there's not a handicap stall available, that definitely can lead to increased risk of dehydration, which can increase just sort of lethargy, thirst. It also can increase risk of things like UTIs, right? So now we're introducing like another medical condition into the picture. All right, constipation. So, I have 2 little boys at home, and I always said I was destined to have 2 little boys because I talk about poop all day long. I am at work talking about poop, I go home and I talk about poop. So nothing is off the table here. Big focus on fiber. So what a lot of people don't realize is that there's actually 2 types of fiber. So a lot of times we might go to the doctor and we're like, you know what, I'm doing okay, but I'm feeling a little bloated, I'm only going to the bathroom a couple times a week, or when I go, I'm having trouble fully emptying, and the doctor says, okay, just increase your fiber, right? High fiber diet. You look online, high fiber diet. But what we don't realize is that there's actually 2 different types. So there's soluble and there's insoluble. So soluble actually bulks up stool and slows digestion. This can help a little bit in case of incontinence. Not so much in the nerve involvement of incontinence, but if it is more desirable for you to have stool moving through your digestive tract at a slower rate to give you more time to get somewhere, that can be helpful to sort of increase that type of fiber. However, if you're constipated, this ain't gonna help. So typically foods that are high in soluble fiber are creamy or sticky when chewed or cooked. So when you think about things like oats, beans, fruit pulp, not the skin, but the inside of an apple or a peach, bananas, sweet potato. Insoluble. This is the one that's going to reduce constipation because it doesn't really get absorbed, it doesn't get broken down as well. This is your roughage. This is the stuff that doesn't dissolve. So lettuce, nuts, corn, seeds, skins and peels, right? So again, apple peel, peach peel. Many foods are going to be some combination of both, right? So if you, I'll take an apple for example, right? That peel is full of insoluble, the inside is full of soluble. We all need a balance of both, right? None of us, no matter what, can't really just have insoluble or just have soluble. We do need a balance, but it is important to note that a dietitian can help you sort of manage the types of foods that you're including in your diet to manage your bowel habits one way or the other. Warm it up. Body likes warm things. Warm things make things bigger, right? Ice constricts, warm things make it bigger. It helps the muscles relax. So if we're having trouble, we're straining, we're feeling really constipated, things like warm apple juice, applesauce, warm prune juice, water, warm water can all help, particularly in the morning when our muscles just haven't quite woken up yet, our digestion hasn't quite woken up yet, we've been sleeping, and so particularly in the morning, that can kind of help things moving. I worked in an ALS clinic in Boston like many, many years ago, and we had this lovely gentleman, and he had a shot that he would take, and it was called the pile dropper, and it was, yes, and it was prune juice, apple juice, bran, and he'd heat it up, and that's just like what he would take a couple times a day, and he'd shoot it back, and I'm pretty sure sometimes he put vodka in it, but I'm not telling you to do that, I'm just saying that was how he sort of managed it, but it worked, right? So you can also take any of these things and warm them up. Warm peaches, warm plums, warm apples. It doesn't just have to be like the warm liquid. And then hydration. Honestly, the best way to check your hydration is the color of your urine. Even getting labs done, that's only going to give you a snapshot of your hydration status, like in that moment when your labs were being drawn. So when you're thinking about throughout the day, throughout the week, your urine color really is the best way to sort of check that. So it really should just be pale yellow. It should not be clear. If it's clear, you're probably washing a lot of good nutrients through, and you might actually be overhydrating, which is a thing. But it also should not be like bright yellow either. So it really should just be like that very kind of pale yellow. And then making sure that you're limiting caffeine and alcohol. One, this can definitely have some interactions with medication, but also they're diuretics. So you may have heard, like, coffee dehydrates you. It's not that it directly dehydrates you, it's just that there are substances in caffeine and in alcohol that stimulate urine production, right? So if you're not making that up and you're not including water and other fluids in there to rehydrate you, then in theory you definitely could be sort of losing more urine, losing more water than you're taking in. All right, so protein considerations. So who here has been told or has heard that you have to sort of be careful of protein with Parkinson's, or if you're on like Cinemed, levodopa, yeah, so a little bit. Okay, so protein is broken down into amino acids. We're going like way back into high school biology here. If you are on levodopa, carbidopa, it also has the same considerations. It can compete for binding sites, right? And when it comes to the body, right, when you think about the body's priorities, right, of like, I need nutrition and protein to stay alive, or I have this like other foreign substance, it's like a medication and it's gonna kind of manage some symptoms, right? Like the body's going to probably take the nutrition in that case. And so they can compete for binding sites. So in some people, it's not everyone, but in some people, if protein is taken at the same time or too close to the medication, it can actually lower the medication's efficiency. And so then the symptoms aren't being managed as well as they could be. So that just means less levodopa reaches the brain, less effective medication. Again, it doesn't happen with everyone. So typically taking the medication 30 to 60 minutes before a meal or 1 to 2 hours after is going to help manage that potential interaction. So really redistributing your protein intake around when you take your medication can be helpful. Now, if you are somebody who's only taking a medication maybe once a day, first thing in the morning, as soon as you wake up, you might not even notice, right? Like you just take it maybe, like I think I put here, I have sort of a sample schedule here. This schedule is for somebody who takes it twice a day, right? But if you take it at 7 a.m., if you can take it on an empty stomach, right, by 8 a.m., maybe you just don't eat the eggs, but like otherwise you can have a moderate protein breakfast and you might not even notice the rest of the day. For somebody who's taking medication 2, maybe 3 times a day, this could get a little bit more complicated. So the sample schedule I have, right, 7 a.m. you take your first dose, 8 a.m. you have a low protein breakfast. On the next slide I actually can show you what that might look like. And I have the schedule up there now in that top right? So 7 a.m. you take your meds, 8 a.m. you have your low protein breakfast, right? You've got oatmeal made with water or almond milk. Almond milk, oat milk, cashew milk are much, much lower in protein. So if you are somebody who is trying to include more protein in your diet, then cow's milk, soy milk are going to be a much better way to go. Lactate milk, because it's going to have that protein. Things like almond milk, oat milk, unless it is like fortified and they've added some protein into it, it's typically going to be very low in protein. The first ingredient for those is actually water. Brown sugar, maple syrup, honey, right, strawberries, coffee, or tea. And then lunch, right? So now we've had our medication at 7. It is now 5 hours later. We're not going to take our second dose for like another 4.5 hours. Like, we can have quite a bit of protein at lunch, right? So sweet potato, avocado, some beans, soup. We've got some peanut butter, apples, bananas, thinning out as needed depending on swallowing function, chewing function, and then water, 100% fruit juice or almond milk, right? So we're adding a little bit of protein in here. It's not a very high protein lunch, but we've got our black beans, we've got our peanut butter, there's probably like a gram or 2 in that almond milk. And then maybe we have a little snack. I didn't put that on here, right? But we have a cheese stick, some cottage cheese, or some toast, something like that, some crackers. And then dinner, we can go high protein, because now we've had both of our doses. We're not going to take our next dose until the next morning at 7 a.m. So pretty much almost, I think 11 hours later, we've got a big difference here, right? So we've got a big piece of grilled chicken, fish, whole grain pita pocket, we've got some hummus in there, we've got some olive oil, and then we can have our like regular cow milk, soy milk, lactate milk, our high protein milk. And then we could still have a light snack such as Greek yogurt or cottage cheese is sort of the example that I have there. So you can see we've got this protein redistribution of like, it's less earlier in the day, and then as the day goes on, we just get a little bit more in. Alrighty, so gut-brain axis. Without getting too deep into the weeds, because I could spend a whole, again, semester teaching this. Our brain and our stomach are there's this nice little highway connecting them. I realize the words are probably a little small. That is okay, because the words are also very scientific. I will break them down into terms that make sense. But basically, we have our brain up top. We've got our digestive tract on the bottom. Particularly, we are looking at like the small intestine. And then at the bottom, we've got all these little buggies and microbes, right? So we've got good bacteria in our gut. We've got bad bacteria in our gut. On any given day, we want them to be sort of living together in this nice symbiotic relationship, and we want them to be working together, and hopefully they're in a nice balance, right? Because if we've got too much bad bacteria, we're probably going to be having quite a few gastrointestinal issues. If we've got, I guess it's hard to have too much good bacteria. It can happen, and that can cause issues too, right? But we want them to just be nice and balanced. So, in our gut, we've got things like melatonin that's being produced, serotonin, dopamine actually. So a lot of people don't realize 80% of your melatonin, which is the neurotransmitter that actually helps promote nice, solid, healthy sleep, 80% is actually produced in your gut. Only 20% is produced in your brain. So that's where a nice, balanced, Mediterranean, plant-forward diet can really help with that. And then we've got, so it sort of sends it up through the brain on the vagus nerve, and then in our brain we also have things like serotonin, which is our happy hormone that's produced both in the gut and in the brain. Our fight or flight takes place in our brain, right? So if we are seizing up, we're nervous, we're anxious, maybe we're experiencing a little bit of depression, that in turn can affect our gut, right? So now we've got less appetite, we've got more constipation, or maybe even diarrhea, some bloating. So again, just a high level overview, this is just to say that the two are connected, and dopamine is one of the neurotransmitters that is involved in that process, right? And we know that we need that good dopamine to help the body to signal appropriate movements. So really quick, this is my shameless plug for the profession. But also, I want everybody in this room to be an informed consumer of just health information and resources. Particularly because you are in New York State. And so there is a difference between a dietitian and a nutritionist. And so a lot of times I feel like I come and I speak at these talks and people get really excited and really inspired and they're like, I'm gonna find somebody to help me with my nutrition. And so they just hop on to Mr. Google and they try to find somebody who's gonna help support them. But in New York State particularly, there is a difference. Dietitian, hi, that's me. bachelor's degree, it's a required master's. I had to go do all of these shadowing and clinical internships, so similar to nursing school, PT school, right, all of that, I had to go through the same thing. I've sat through a national board exam. I have to maintain my registration every few years with continuing ed, and I have to not just speak at conferences, but like go to conferences and sit through webinars and all sorts of things. I am legally qualified to practice medical nutrition therapy, right? So somebody can come to me with Parkinson's and say, hi, I need help with my diet, and I can say, great, okay, any other dietitian can hopefully help with that. And we're held to a professional code of ethics. In New York State particular, there's a few other states, just unfortunately New York State happens to be one of them, anybody can legally sort of practice nutrition and disease-specific nutrition. They're not allowed to call themselves a dietitian, but they would call themselves a nutritionist, so there's just no universal requirement. You could have a PhD, you could have like an online certificate, and you could still call yourself a nutritionist. Typically focusing on general health, but like I said, I always just like to put that out there because this is an issue that is more specific to New York State than anywhere else. So if you're looking for more information, really try to find somebody if you can with that RD credential. And then just these are two of my favorite resources. We do have the Academy of Nutrition and Dietetics, which is eatright.org. They also have a Find a Nutrition Expert database on there, so you can go, you can search by disease states that you're looking for or conditions, right? Maybe you feel like right now, like your Parkinson's is well controlled, and that's not necessarily what you want to talk about with nutrition, but maybe you want to talk about maintaining muscle mass and constipation, right? So maybe you don't need a neuro-specific dietitian, but you certainly could find somebody who's maybe good at managing GI disorders or something like that. And then Harvard School of Public Health puts out an incredible publication on a regular basis called The Nutrition Source, and it's always very like frontline, cutting edge. All right, thank you. My email is here. Just note that is not a typo. It is .io at the end. And then if you scan this QR code, that will bring you to just one of my web pages. So if you want to call me, email me, send it to a friend, you can do that too. There's also other dietitians on that page. It's not just mine. It's a full database. Great question about timing the schedule for 3 times a day. I'm assuming that is a protein question, if you're taking medication 3 times a day. And so really what you would want to do in that case, and if you want to take a picture of this, if that's helpful, the recommendation again is that 30 to 60 minutes before, 1 to 2 hours after. So you're probably, if you're taking your medication 3 times a day, you're probably going to be one of those small, frequent meal people. You're going to probably be one of those people that's going to benefit from things like almond milk most of the time. The body can only process, this is where it gets a little tricky, the body can only process about 30 to 35 grams of protein at one time, like efficiently. And so actually while I was preparing for this, I went into ChatGPT and I was just curious what it was going to spit out. And I was like, send me a Parkinson's redistribution diet for somebody who's taking medication like 2 or 3 times a day. And basically it was like, no protein, no protein, no protein. 60 grams of protein for dinner. And I was like, oh, it was so close. So it's almost there. So if you are somebody taking the medication 3 times a day, you probably would just need to work that. You would have to really just be very diligent about eating probably every like 3 to 4 hours and doing like some moderate protein in there. And then most of your protein probably at the end of the day or a high protein like bedtime snack. All right, oh, I love this one. Magnesium seems to be the hot supplement. It comes in many forms. Does it help with muscle, mood, sleep? Most people are not going to be deficient in magnesium. You can take mag citrate for constipation, so that form can help a little bit with constipation. There is some research out there about magnesium glycinate for sleep. Any sleep supplement, I always like to remind people, it's just that, it's a supplement, it's not not a sedative, so don't expect to like take magnesium and just knock out. But again, if there is any sort of deficiency, right? Like we lose magnesium when we're working out, right? So if we're somebody that we're going really hard in PT and we just happen to notice that every Tuesday, Thursday, when I have a really hard PT session, my muscles feel kind of sore, right? They feel crampy, or they feel kind of funny, and I'm having trouble sleeping at night. You might be somebody who would benefit maybe from a magnesium supplement. Suggestion for improving diet to manage constipation. Primary suggests Metamucil. Yeah, so I think fiber supplements definitely is one case where sometimes it can be hard to get all your fiber in. The fiber recommendation is 25 grams a day for women, 35 grams a day for men. And so that can be a lot. That does typically end up looking like about 5 servings of fruits and veggies a day. So depending on where you are with appetite, swallowing, time of your medication, trying to make it to appointments, adding a supplement such as Metamucil definitely can help. Alrighty, I'm gonna hang up that. Let's see, what else? Does an anti-inflammatory diet also help inflammation in the brain? Yes, does inflammation in the brain, is that related to Parkinson's? So when we're talking about inflammation, we're really talking about, again, at the cellular level, whole body inflammation. I think what we think of with inflammation is like swelling almost, right? And so that's not quite what it is. When we're talking about inflammation, we're really talking about the cells are not working at their max capacity. So it's not so much that it's an anti-inflammatory diet. You just want to make sure that you're including foods that have anti-inflammatory properties. So those heart-healthy fats are really rich in omega-3 fatty acids. Those omega-3 fatty acids have a lot of anti-inflammatory properties, right, to help with good blood pressure, good blood flow. Same thing, fruits and vegetables, right? They've got some anti-inflammatory properties that really help with immunity. If our immune system is working really well, our body's not going to be experiencing as much inflammation. Would probiotics be beneficial? Yes, I was expecting this question. So probiotics are another really hot topic right now. Like I said, most of us have pretty good gut bacteria, right? Like the body is really good at maintaining homeostasis and adapting as needed. There is some emerging research that extended probiotic use, particularly with people who don't need it, actually can lead to some potential antibiotic resistance. So I am not the dietitian who's like, yes, everybody should be on probiotics because it would help everybody. That is not necessarily the case. If you are experiencing some gastrointestinal issues such as constipation or diarrhea, it could help. It does take about 3 weeks to see any results. I would say try it for a month, and if it doesn't work, then it might warrant more exploration. You also can get probiotics from food. So we talk about it from the supplements. There are billions of strains of probiotics, so you also might want to work with somebody who knows what strain might be good for you, because not all strains work on everything. But you can get probiotics from things like yogurt, fermented foods, cottage cheese has a little bit, miso is another good source of probiotic as well, so you can get it from food. Oh, another probiotic question. Canola oil, seed oils, yes, are they bad for us? No, they're not bad for you, that's not what I meant. The question is just asked that they're bad for us. So there was a study done, it was a terribly designed study. It was done on rats, and basically they gave these rats a whole bunch of seed oil, so things like canola oil, for example, and they also gave the rats like all this other stuff and processed foods that contain these seed oils, and the rats developed some cancer markers. And so TikTok got a hold of that, because of course TikTok gets a hold of everything, and it just became this like big PR nightmare of like, oh my goodness, seed oils are terrible for us, but they ignored like all the other things that were in the stuff that they were giving the rats. So that being said, olive oil is always going to be like king, I guess. Now, I don't know about you, but when I'm eating my blueberry pancakes on a Saturday morning, I don't want them to taste like olives. So the next one after that would be something like a canola oil, which is a seed oil. The American Heart Association is still maintaining that that is a very heart-healthy oil with some anti-inflammatory factors. The Academy of Nutrition and Dietetics says the same thing. So that seed oil attack, I promise that they're fine, they're good for for you. When it comes to some of the fats though, one thing you do want to think about, a good sort of rule of thumb, is sometimes like how liquid, how soft the fat is at room temperature. So if you're thinking about something like olive oil, right, it's liquid, right? It's soft at room temperature. When you think about something like coconut or lard, Crisco, right? It's very solid at room temperature. Even things like butter, that's kind of where you're getting into the weeds a little bit. All right, can we have 5 minutes to stretch? I think you're getting 15 minutes after I'm done. Gastroparesis demands a diet that's opposite of what's usually advised. So nausea, vomiting is typically addressed with a diet low in fats and no whole grains. That is so confusing. So gastroparesis, that is something where you probably do want to work very closely with a nutrition professional, because it is going to be a little bit more individualized for anybody who isn't sure what gastroparesis is. It's sort of like a paralysis of digestion, basically, right? And so you're eating things have to go somewhere, right? And if they're not moving down, they're probably going to start moving back up at some point, right? And that can result in a lot of nausea and vomiting. And so yes, diet low in fat can definitely help with that. Whole grains, if it were me, I'd probably still include some whole grains in there, because you really want things, you want to stimulate the gut a little bit, but definitely with gastroparesis, small, frequent meals is going to be your friend. Like eating very, very small amounts, because if things aren't moving all the way, the last thing you want to do is like dump loads and loads of food in at once and just cross your fingers and hope for the best. So having those smaller, frequent meals, lighter meals that are easily digestible. I think sometimes when doctors say things like no whole grains, what they're really trying to say is eat blander foods, right? So a lot of times, yes, that might be a case where things like saltines and white bread might be really helpful. It doesn't mean that there's not a place for whole grains, right? Like you still could definitely have some of those sources of insoluble fiber. Let's see. All right, and then I have one more. I'm going to try to answer this one as best I can. Are microplastics causing inflammation or damaging our bodies or brains? Wasn't like specifically part of my RD training. However, there is definitely research. I think it's very emerging research. I don't know if I can say, is it like causing inflammation? I think there are some studies that it might be contributing to some negative health outcomes for sure, but you can also find both sides, right? Like I was just reading an article the other day about like sparkling water, right? It's just as hydrating as water. It's got some bubbles in it. If you don't like plain water, then go ahead and have sparkling water, because it's a great alternative. That is true. And then I saw another study that was like, well, the can lining of the sparkling water might be leading to some other things. And if you're not really looking into the research, you might just see the headline of like, sparkling water causing cancer. So I think that there definitely is a correlation. I think it is important to just be smart consumers. I also recognize that I can come from a place of privilege where I can afford really good groceries, right? And not everybody can do that. So I think that it is a bigger conversation, right? I think it would be amiss if I were standing up here and not recognizing, right, that there's also food insecurity and things that also kind of go into some of that too. So, all right, I think that's it.
Diagnosed with Parkinson's disease in December 2015 at the age of 40, Brian chose to take an active role in managing his diagnosis from the very beginning, immediately joining a Parkinson's-focused workout class and prioritizing movement and wellness. He delayed medication for a year, focusing instead on exercise and lifestyle adjustments. In February 2022, Brian co-founded the Secret Life of Parkinson's podcast alongside Jessica Krauser, Melissa Carlson, and Steve Brandenburg. The podcast is dedicated entirely to real conversations about living with Parkinson's, focusing on honesty, resilience, and life beyond the diagnosis. Brian underwent deep brain stimulation surgery at the Cleveland Clinic in June 2022 and continues to stay active through PD Next Steps workout classes. Now nearly 10 years post-diagnosis, Brian continues to work full-time, proving that Parkinson's may shape his journey, but it does not define his limits. Welcome, Brian.
Thanks. First of all, I will start out apologizing. The last couple presenters have been so polished, so professional, so knowledgeable, and for the next half hour, you have me. So, anybody else wake up feeling like this today?
Yes, I love it.
That's almost me every day when I wake up. It doesn't mean I don't want to meet you or talk to you, just means it's a little bit of a struggle. Like I said, my name is Brian, or like she said, my name is Brian Baker. I'm a patient advocate and ambassador for Changing Parkinson's. Did I do this right? Wow. Who I am. I'm a person with Parkinson's with a young onset. I'm a person with opinions. I'm a person with real life experience. What I am not a medical professional. I'm not certified as Allison in anything. Well, let me change it. I might be certified in certain other ways, but. And I am not a professional speaker, so I may lose my train of thought at times. Bear with me. As I said before, I am a patient ambassador for Changing Parkinson's. This became a real thing, a grassroots effort, when Jessica Krauser, the co-host, was diagnosed. Some friends of hers wanted to get together and do something for her, so they started the 5K for JK. The first year they raised, I think, 80, maybe 100,000. They donated all that money to the Michael J. Fox Foundation. The next year, she said, hey, I want to keep some of this money here locally. And that's when she developed these kits that they just gave out. Inside the kits were notes from her and everybody else that had helped put them together as far as things we wish we would have known when we got diagnosed. The toothbrush was my idea because it took me probably a year and a half, 2 years to feel I couldn't make the motion to brush my teeth. And I thought, buy an electric toothbrush. It took me 2 years to figure that out, so I'm a little bit slow. Bear with me. Then Jessica joined the gym with PD Next Steps. It was kind of funny because when they were talking about their thing, their last slide said next steps. And that's exactly what Melissa started. When Melissa started this gym, that's what she wanted. You've been diagnosed with PD. What is your next step? And then we developed the Secret Life of Parkinson's podcast. Maybe I'll be able to go to the next slide. So they've developed this into 3 pillars: community, exercise, and education. Man, she's sneaking up on me. I thought she All right, now they can hear me. So inside those kits are a water bottle, a journal, a book from Dr. Mathers on shaking hands, how to talk to your kids, grandkids about Parkinson's. A big list from the National Parkinson's Association of medications to avoid. That is critical because when we go to the hospital, they don't know what they don't know. They give us medication, dopamine depleters, so therefore we start to hallucinate. They give us more medication to calm us down, which is making our hallucinations worse. So that's important to take with you. Electric toothbrush and everyday tips. In 2022, after Jess and I were sitting in the gym talking, we always had really good banter back and forth. And I I made a joke about having a podcast. Well, Steve Brandenburg overheard that joke somewhere in there, and he's, oh, you guys want to do a podcast? Great, come to my house. So we went to Steve's house. He go up into what his studio is, and he used to own a production company. So it was a legit studio. Here we think we're gonna use our iPhones, and no, he's got cameras, he's got lights. So what, 4 or 5 years later, we've got actually over 200 episodes, 15,000 subscribers, over 2 million views. Global an audience, we get messages and comments from everybody around the world. So if you're interested, and a lot of times it might be just Jess and I talking, real life talking, raising kids. We have medical professionals. We talk about constipation. We talk about sex. We have one episode where we talk about sex. Very uncomfortable, very uncomfortable. So yeah, that's the podcast. If you get a chance, check it out. Leave comments. We try to interact with as many people as we can through comments, suggestions. We give people the opportunity to tell their story. Newly diagnosed. What are you feeling now? So there's my sales pitch on changing Parkinson. It's all grassroots effort, like I said. It's all, here she comes again.
Sorry, you're good.
Next is gonna come. So like I said, we got over 200 or 2 million views. If anybody has topics, we're open to suggestions on topics. We have medical professionals from Ohio Health on there quite often. We have medical professionals from Cleveland Clinic on there. So let's get into the journey. Diagnosed in 2015 at the age of 40. Hang on, she's gonna get to the end. At the age of 40, I was diagnosed. 2 to 3 years prior to that, I had symptoms. I'd gone to my primary care for, my physical, I think, and I said, I felt like I was dragging my leg. People at work were asking me why I'm walking around with my hand like this in front of me, like, what's wrong with your arm? Like, nothing's wrong with my arm. What's wrong with your arm? And so I asked my doctor about it. He's like, oh, no, it's just tendonitis from lifting from your gym workouts, and I don't see anything wrong with your leg. And he just dismissed me. About a year and a half later, I went to another doctor in his practice because he wasn't available, and she was right out of med school. And I told her what was going on. She said, oh, let's check for carpal tunnel and see how that goes. So she took me for carpal tunnel. The neurologist comes in to review the evaluation of the carpal tunnel. He goes, nope, you don't have carpal tunnel. Looks at my handwriting. He says, is that your handwriting? Well, yeah. It's about that so small you couldn't even read it. He didn't even make recommendations, didn't say anything. He didn't send the results back to the primary care. So 6 months later, I'm watching the news. I literally get home, I click on the TV, and I'm doing something that says something about Rock City boxing. I had to take a step back, and I was like, what is this? I'm kind of interesting. Then it was about Parkinson's and Rock City boxing, and then they go through the whole thing, and they gave like the 5 main symptoms of young onset Parkinson's, and I said, I have Parkinson's. So I diagnosed myself. I then called my primary care, and she said, oh, come back in, Brian, I'm sure you don't have Parkinson's, but let's get you looked at. So to bring him back in, she said, let's just get you to a neurologist. I go to a neurologist. It's interesting. He said, Brian, you have Parkinson's-like symptoms. I can't tell. You're so young. What's going on here? Let's get blood work done. So they run like 300 tests and blood work. He said, Brian, there's a lot that can mask as Parkinson's. There's Lyme disease, metal in your blood, chlamydia, gonorrhea. I'm like, oh, please have chlamydia, come on. Gonorrhea, be a winner. Obviously it wasn't, so. Then they moved me to a move-in, he said, Brian, I don't know, I am baffled. So he sent me to a movement disorder specialist that just started there at the Ohio Health Network. Once again, it took 4 months to get in to see him. So in December of 22, December of 2015, I was officially diagnosed. Within a week of being diagnosed, I was in a Parkinson's workout class. I had always gone to the gym, had always been active. I walk into that class, and I'm the youngest person by 20 years easily. And I thought, what am I going to get out of this? Nothing. Then I met Marlene. Marlene was 70 plus, and she kicked my butt. And I'm not joking. She was doing stuff. I was like, I'm in shape, man. Marlene was this little gray-haired lady. And she was running faster than I was. She was lifting more than I was. And I was like, maybe I am going to get something out of that. So I did. A community that, I keep forgetting to hit the slides. Yeah, that's it. But a community-based workout is great for me personally versus a home-based workout. We socialize. Hey, Marlene, what kind of medication you got? You got any carba? Got an extra pill of cinnamon in there? Yeah. So, what medications, what people are going through, you start to learn their families. Hey, how's your granddaughter doing? It's just that, man, there's people out there that understand when I say I'm having a shitty day. They understand what it's like. Because as much as my girlfriend tries to understand, she doesn't know what it's like. Sorry, she doesn't. So when I say, hey, I'm not having a very good day, Marlene understood, Jess understands. So it's good to have people around you that understand. It's also good to see people living their life. When Dr. Hinkle diagnosed me, he looked at me, he said, Brian, you can either go home, and this is the very first appointment with him. He said, you can go home and you can sit in the corner of that couch. 20 years from now, you're going to wonder why you didn't live your life. Or you go live your life. And I'm choosing to live my life. I had to fire Dr. Hinkle, by the way. Which that's down here. So let's get to what you guys really cared about, which is probably the DBS surgery. So that's why I had to fire Dr. Hinkle. I went into his office for my appointment and I said, Dr. Hinkle, what's this DBS stuff I'm hearing about? I want to try it. And he looked at me and said, we're not there yet. And I said, what do you mean we're not there yet? He goes, I don't think you're advanced in your Parkinson's enough. And I said, okay, thanks. I walked out. I said, called the next appointment. I went to Dr. Patel. I walked in there and Dr. Patel said, have you thought about DBS? I said, you're my type of doctor. So that's one thing, is find a provider too that's on the same page with you. I got the utmost respect for Dr. Hinkle. I see him all the time, I talk to him. We weren't on the same page at the same time. He's now, I think, changed his opinion. And luckily enough, I've got a network of movement disorder specialists and neurologists to choose from. So that's an advantage that I have that a lot of places don't. But yeah, I mean, make sure that providers understand with you. If medications aren't working, what else out there? If medications are up or down, just make sure that they're on the same page that you're on. All right, my DBS journey, which is what I am here for. So, I chose to go to Cleveland Clinic because why not? If you have the option to get the best treatment, go get the best treatment. Cleveland Clinic is about 2 hours north of where I live, but they had done DBS for, at that point in time, like 15 years, I think 10 to 15 years. They had a team, that's all they do is DBS surgeries, so that's where I chose to go. There is testing that gets involved, and in that testing, so what you do is you go the day before, you go up the day before, and DBS is deep brain stimulation, if you didn't know. So you go the day before, you go in for testing, they do a cognitive test, where they read a story to you, and then you have to repeat it back to them. Give you a list of numbers or letters or different things, and you have to repeat it back to them, basic stuff. Go through the testing. One day you stay overnight at a hotel. Next day you go in off your medication. They compare, hey, this is Brian on medication, this is Brian off medication. Will DBS be successful with him? So then they meet all the doctors, the physical therapists, and psychological therapists, psychologists, and stuff like that meet, and they say, yep, Brian is or Brian's not. And I was. I didn't really have any fears initially. I had two people I worked out with that had gone there and had the same surgery done successfully. They had good results, so I didn't have any fears going in. Now there's a reason the day of surgery that they make you take off all your clothes before they roll you back to surgery, because as I'm sitting here in the hallway waiting to go in the operating room, I'm going, what are you doing, Brian? I mean, and honestly, had I had shorts on, I probably would have ran. I was like, hey, this is not, there's nothing wrong with your brain. Why do you have it operated on? So that day there was a little bit of fear as they're rolling back there, and the surgeon looks at me and said, Brian, your blood pressure is a little bit elevated. I'm like, no shit. You're getting ready to cut into my head. So there are several kinds of DBS surgery that you want to ask about. STN is the most common surgery for DBS, and all it is where they put the leads. So STN is one, and GPI is the second one. Each one of them has a little difference depending on what your symptoms are. Day of the procedure, so with Cleveland, you go in, you check in the night before, they roll you down there about 7 o'clock in the morning, they do the surgery, they bring you in and out of consciousness. So they would shave your head, so that's cool. I was like, hey, thank you. $75,000 for a haircut. If you had left the bangs a little bit longer. No, but they shaved my head. They put this halo thing around me so I can't move my face or my neck or my body pretty much. Then they would knock me out, drill the holes, put the leads in, wake you up, turn them on, test everything. It takes about 4 hours, I think, for the whole thing to happen. Cleveland Clinic, they do these multiple ways depending on where you go. Some places do both sides at the same time. Some places, Cleveland Clinic does not. They did my left side. Let's take a look. So they did my left side first, my right side second, about a month later, then about 3 weeks later they did the battery implant. Yes. Great. Yeah. I said, Caleb, he was the guy that was physician assistant that cut my hair. Like, you think you could do a better job this time? I'm short, I'm chubby, I had good hair. Can you leave a little bit of it? But back to the whole point is, So some places will do both sides at the same time, same day in surgery, some places, and it's all preference. I don't know what the surgeon feels is the best for him. Cleveland Clinic has 3 or 4 people that do this, and they just want to be consistent and do it all the same, so they choose to do it this way. But there's no right or wrong way of doing it. But they would bring me in out of consciousness to test it. So they wake me up, they would say, you know, do the days of the month, do the months of the year, the days of the week, ask me questions, turn it on, move it around a little bit, make sure they got the thing set exactly where they wanted to. Recovery, there's no nerve endings inside your brain, so nothing hurt. If you're lucky and you have this done, you can get what they call a honeymoon stage, and I got that, and I thought I was cured, but then it came back. The honeymoon stage, basically, from them doing damage to your brain, it releases all the dopamine, a bunch of dopamine into your system, and therefore it gives you. I had like a week where I didn't have Parkinson's again. I was like, this is great. I mean, I was making plans to travel, camp. About a week later, no. So, the one thing about DBS, it's a process. Let me stress it. It is a process, okay? It's not surgery and you're better. Surgery is not a cure. It's a treatment. By the time, once you get the surgery done, you get excited, they're going to turn it on. They have to program it. So they have to get those leads touching the right part of your brain. So depending on how many leads you have, or you have 2 leads, but how many places you have the electric turned on. So for mine, I believe I have 8. So if this is inside my head, there's 8 connections up and down here. They can turn some of them on, they can turn all of them on, depending on what parts of my brain they're trying to touch. So therefore, like I said, it's a process. And sometimes, for me personally, I did 3 sessions of the thing being turned on, or 3 programming sessions, and they hit it, boom. I was good to go. I got a good friend of mine, she's probably gone to 10 programming sessions. She's not having a lot of success with it. So it's a process. Everybody else is individual. Just like the disease, the treatments are all going to be a little different for everybody else. The outcomes, I love it. I would do it 100 times again. I am not on any medication, which is uncommon, because you're usually still on medication or some type of some sort. Since I've had it done 4 years ago, I have not taken any medication. Depending on what you think, some doctors say you should still be on it. I should still be on it. Sentiment just makes me so tired. Side effects, questions asked when you're going to go. How many surgeries have they done? How do they do it? Do they do it on both sides at the same time? You have your choice of what product you want. There's 3 major players out there. You have Abbott, Boston Scientific, and Medtronics. Each one has their own little thing that they're known for. Ultimately, they're all the same. Well, not the same. Medtronics has an adaptive component to it where you can turn on it and it adjusts itself. I do have a remote control that I can take mine up and down. Some. Take it gone into neurosis. If I do it again, obviously it's that. So, in closing, let me leave you with this. Jake and Bert are sitting on a bench. Bert looks at Jake and says, Jake, would you rather have dementia or Parkinson's? Jake's like, that's easy. I'd rather have Parkinson's. And Bert's like, what do you mean it's easy? Why would you say that? He said, well, I'd rather spill half a glass of bourbon than forget where I put the bottle. So, if you have Parkinson's, look at your shot glass half full. Thank you. Tremors need to meet a standard to trigger DBS. I don't know if there's a standard. I shouldn't say never. I haven't had I'm not tremor dominant. I'm rigidity, stiffness. I will say the one thing I found out from seeing people with Parkinson's get DBS, the more symptoms you have, the harder the programming goes, because they chase that tremor down and your rigidity gets worse. You get to chase the rigidity down, all of a sudden your dyskinesia gets worse. So finding that balance of what's right, what's wrong. Have your programmer at your sessions when you're being programmed, or have every rep. There's a rep for Boston Scientific that's responsible for this area, and a rep for Abbott, a rep for Medtronics. They know more about their product than the neurologists do. But this is just a small piece of what the neurologists do or the programmers do. That's what these guys do for a living. So they can say, hey, what if we move this here? What if we turn this on? What if we turn this off? So require that. Tell them, hey, I want John from Boston Scientific to be at my programming session, and they'll be there for you. First step kits, if you go to the website changingparkinsons.org, we'll ship it to you for free. Yeah, how do you change it at the primary care level? That's a big mission that we talk about a lot of times on the podcast. Because how many of you, if anybody, how many people have you been told, have been told, oh, you have Parkinson's from a primary care? Here's Sediment, take one pill 3 times a day, bye, see you in 6 months or a year. I mean, I talked to so many people that's what they were told. Don't settle for that. You have to advocate. If your primary care has said you have Parkinson's, you need to get in to see a neurologist and preferably a movement disorder specialist. Oh, can it be reversed or revised? Reversed if it doesn't work? Yes. There is, number one, you can just turn it off. It's still in there, but it's turned off if you're having problems. Second of all, they can take it out. Now, that's not ideal, but they can. How do we find the podcast? Great question. How about Secret Life of Parkinson's is the name of it. You can Google it. It's called The Secret Life of Parkinson's. And really, I didn't even know why we named it that until recently. And I was like, how did we just like, you didn't know how you came up with this name? I was like, no. But hey, we all try to keep it a secret. We all try to, hide our Parkinson's. And so we kind of come out and said, this is a secret life. So this one, did your neurologist steer you towards DBS? Like I said, Dr. Hinkle said we aren't there yet. There used to be a stigma that you had to be so far advanced in your Parkinson's before they would consider DBS. What they found is the earlier you do it, the better the results are. Meaning, better quality of life. My Parkinson's is still progressing. It didn't stop progressing, but I've had good quality of life better than I did with medication the last 4 or 5 years. So, So yeah, Dr. Hinkle did not, Dr. Patel did, and that's why I went with Dr. Patel. And once again, the kids, changingparkinsons.org. What's the primary symptoms that DBL has helped with? My stiffness and rigidity. If you watch the podcast, you can see in there where I have very bad dyskinesia, where I can't hardly sit still at times. And so that's gone away, so it's helped with that. So dyskinesia, dystonia. Same question here. Yeah, I'm still in exercise. I still exercise now. One of the side effects to Parkinson's or to DBS, I recently found out it has been weight gain, so that's what I'm blaming it on. So, which makes sense. You're not moving as much, you're not shaking as much, you're not burning calories as much as it makes sense. That's a real thing. So, is that it? Is that all the question? Am I done?
Last but not least, Dr. Christopher Bishop is a professor of psychology and director of the undergraduate integrative neuroscience program, whose work centers on the science of movement and its disorders. Movement is a fundamental biological function essential for survival, and when it's disrupted, quality of life is profoundly affected. His research primarily investigates Parkinson's disease, a neurodegenerative disorder that damages dopamine-producing regions of the brain and impairs a person's ability to initiate and control movement. Using animal models of Parkinson's disease, Dr. Bishop integrates gene therapy, chemogenetics, and neurochemical approaches to study the brain circuits and neurotransmitters involved in motor dysfunction. That's a lot of big words.
Yeah, sorry.
His laboratory also identifies pharmacological targets that may lead to more effective treatments. Supported by the National Institutes of Health and private foundations, his work explores neuroplasticity within motor symptoms as a promising avenue to reduce symptoms and minimize side effects associated with long-term drug therapy. As a mentor, Dr. Bishop views training as a collaborative partnership. He emphasizes rigorous application of the scientific method, technical mastery in advanced neuroscience tools, and clear communication of innovative research. Students are encouraged to pursue interdisciplinary training and grant writing to prepare for independent and successful scientific careers. Welcome, Dr. Christopher Bishop. Sure, but stay within the range of the table, okay?
Yeah.
Doing the video.
Yeah. For our home audience, yes. Thank you so much. I really appreciate the opportunity to be here today. I feel like, in some ways, I'm fortunate to be last because they set some of the things up so well that I want to talk about today. And I'm going to focus a little bit on one part of our research that we do it in the laboratory, but really, I think for this audience, it's really important that we talk about things like neuroprotection. So we've talked a little bit about some of the reasons why Parkinson's disease occurs. One of the main reasons Parkinson's occur is aging. Now, here's the thing. Living when we do, we're fortunate. There have been changes in care, nutrition, that have led to us living longer. That's good stuff. But there's a risk to living longer, and those things can be physical risks, things like arthritis, frailty, falls, as well as cognitive risk, things like memory problems, attention, flexibility in the way that we think. I sometimes struggle to come up with words and names. It's normal, okay? Now, people with Parkinson's have problems with movement. I don't need to tell you that. And they also occasionally have problems with cognition, right? And some of this has to do with the disease, and some of it has to do with aging. I feel like I may have failed you. I've been working in this field for 20 years, and thousands of us are working in this field. We don't have a cure for you yet. I work as an advisor for Michael J. Fox Foundation, so I get to hear the things that are happening in this field, and I am excited for what's happening in this field. Right now, what we have for you are treatments, and treatments are improving, and you know about these treatments. Some of these treatments are going to be drug-related, levodopa, so levodopa carbidopa, Cinnamon, maybe dopamine agonists that you've taken or are taking now, as well as additional medications that might help you with your side effects. There are ways in which we deliver these drugs that are different. There are extended release formulations now. There are pumps and gels and things, especially for later stage Parkinson's disease. And then we heard about deep brain stimulation and the changes that are happening now in that field, including adaptive DBS, which actually allows the system to pick up changes in movement through your brain that in turn can make short adjustments that might help you with things like freezing, all right? But to this point, these treatments do not change the progression of the disease. So that leads to this question: what can we do? Now, as somebody who has been in this field for a couple decades now, my way of thinking about this has changed, right? Because, and I do certainly work on the treatment side, okay? I'm a pharmacologist by training. You heard about it. I work with animal models. We're trying to develop new drugs that will help with symptoms or maybe help your drug to last longer and keep working. But I feel like our goal should be disease modification, right? Changing the progression of the disease. And in order to do that, what we're really talking about is neuroprotection. Neuroprotection. So if I was to think about what I would want from a strategy like this, here are some of my goals. That it would be inexpensive. That it would be accessible, right? So that everybody here would have an opportunity for this strategy. I also think that for me, and I've talked about changes in movement and cognition, that this strategy should be something that would affect the entire brain. Not just one little area, but perhaps the entire brain. And if I had my druthers, as a pipe dream perhaps, but we'll get back to it, I would also want it to be restorative, meaning something that actually maintains cells longer, slows the progression of the disease, or even brings some cells back to start working again. Wouldn't that be great, right? So what do I do as a scientist? Well, I've got at my fingertips thousands and thousands of papers studying the brain. Some of that stuff is directly related to what I do. Sometimes it's in an adjacent field, but those fields often contain clues that let us look more deeply into some of these questions. So that's one of the things that I did, along with many of the others who've done work before this. And I landed on one area in particular that was intriguing to me. Now, not here to give you a lecture like I give my students about brain development, but let me tell you, brain development is incredible. If you think about the first 12 months from conception to birth and those 3 months after, human brains go from 2 cells to billions of cells. There are times when the brain is making hundreds of thousands of cells per minute. So what's the stimulus, right, that leads to this increase in brain cells? We'll put a bookmark in that. We'll come back to it in a second. There's another time in all of our lives where we make new cells, and that is when we learn new things. When we learn new things. In order to learn new things, we actually have to create new cells. Doesn't matter what age you are, you still need to make new cells. You've got to make new neural pathways. How else do we make a memory, right? It's a physical change in the brain. So these two things are happening. What's the stimulus, or what's in common that might help us protect our brains? And the answer is neurotrophins. Has anybody heard of them before? Okay, I've got a couple. It's okay. How else would you have known? Well, you're here now. You get to learn more about them. They're beautiful. Look at those things. Those are the structures. Okay? Neuro, brain, central nervous system. Trophins, growth. That's kind of where that term comes from. All right? They come in different flavors. We've got brain-derived neurotrophic factor. There will not be a quiz. Nerve growth factor, and then vascular endothelial growth factor. Now they do really interesting things for us. Not only do they serve as one of the stimuli during brain growth and learning and memory, but they do things like help with branching of brain cells, help with connections, and even improve blood flow. They're there. We all got them. Oops, that's the wrong direction. You already heard that. So here is a video of what neurotrophins do. So I want you to look at the darker cells here, and we'll see if they get started. Let me try it up here. Oop. I'll tell you in a second. All right, so it's okay. Well, we're cool with the video if it doesn't start. What we find when we add neurotrophins to these cells, okay, is that they start off undifferentiated. You can see how these black ones are there. As we add neurotrophins, these cells begin to grow out. They spread their projections, and they start to connect with one another. So all of those things I talked about, right, like branching, connections, and even better circulation so that they get more oxygen, so that they get more energy or fuel, is instigated by these neurotrophins. All right, so that comes to my next question, which is how can I get me some of these neurotrophins, right? It's a fair question. You got some now, but maybe you want more. Nope. Here's problems. There's problems. They don't cross the blood-brain barrier. You can't just take a shot of neurotrophins, right? The brain's actually very good at protecting itself, and it doesn't let a lot of stuff in, all right, especially big stuff. So it's like, nope, you can't get in this way. No pharmacologic agents that directly lead to neurotrophins. And then finally, if we had a way to actually deliver neurotrophins, it would probably have to be directed into a particular site. And those things aren't really available to us right now. But there are ways. There are ways. Remember I said there were clues? There are clues. All right? And today I'm going to tell you about 2 different types of exercises. Thank you for all of you who've talked about this already. I'm just going to tell you how, okay, and give you some results of some really cool stuff that I think are really pertinent for us here today. First thing you can do, cognitive exercise. I like to think of this as preserving the software that your brain runs. how can we keep that stuff, right, which happens naturally, augmented and maintain the software of our brains? The adult hippocampus, again, no quiz, okay, is right here. See it? Right here. And if you look at it, it actually looks like a seahorse in our brains. That's where hippocampus comes from, in case you're curious. This is an area of the brain that creates new cells throughout our life. It's one of those areas where you can continue to make new cells. So, if we look at somebody's hippocampus after learning, and you look at that top panel up there, see all those red arrows? Even in the back, some of you can see it, good. If you can't, there are a bunch of red arrows. Those are new cells that were created after learning. Brand new cells, making new connections. You can block that by using chemotherapy. So something that suppresses cells and growth of cells. And if you do that, and it's one of the reasons people that are taking chemotherapy have problems with memory, because we're actually preventing those cells from being born, right? So this seems like a good strategy, right? Learning and memory to preserve our brain. And we know this now from the field, okay? We know this whether it's in aging, whether it's in mild cognitive impairment, whether it's in Parkinson's disease, that engaging in complex cognitive activities can preserve brain function and limit cognitive impairment. Now you might ask yourself, well, what are we talking about here? I do the crossword once a week. No. We gotta do better than that. The best thing you can do is varied exercises for your brain, and they gotta be tough. They gotta be, well, you heard from the physical therapists, right? They didn't say you can't just walk around a little bit. We're talking about spending some time working that brain out. All right, so maybe it's complex puzzles, but how about continued education? Well, you're here today, that's amazing, engage it. Continue to engage it. Engage in music making. You know, there are even computer exercises and games online that are actually really good for your brain. The more of these you do, the better off you're going to be. Just make sure they're varied and sufficiently difficult. That's going to be an underlying theme for this talk. Second thing, physical exercise. Okay? Kind of know that. I feel like you're an informed group. I love that. Here we're talking about preserving the hardware of the brain, the actual cells that support cognition and movement. We've known for some time that exercise reduces the loss of cells that would normally occur in Parkinson's disease. We've known it for a while, okay? Now, sometimes exercising throughout your life can delay a diagnosis. But instigating exercise at any point, as we've already heard, also slows the development of the disease, and it can maintain you in a lower stage for a longer period of time. So these are my subjects, okay? Just to be clear, I am not an MD, I'm a PhD, which means I spend a lot of time reading books, not working with people, okay? But I do work with rats. And it's the way that we study the basic biological changes that occur in the brain, all right? And here's one thing I know. Well, first of all, I know that my rats are aware of the importance of exercise. Because if I let them run on a treadmill, they'll run multiple miles a day. they actually enjoy it. Mice will run up to 9 miles a day if given an opportunity. So they know something, right? They're engaging in exercise. So we can run our rats on a treadmill 3 or 4 times a week, and we can look at how exercise modifies their motor performance. And the types of things that we found replicated in humans is that this type of exercise increases blood flow, heart rate, several indices of brain health, and helps with not only motor symptoms, but reduces side effects of medication. So some of you may experience things like dyskinesia. Brian talked about dyskinesia. We find that medication plus exercise is actually an optimal way of treating the symptoms of the disease. So it is worthwhile asking this question, right? Like, that seems pretty dangerous to me. I would not recommend a running wheel for humans. The mice like it, but they're 4 foot and everything. There are many ways to get exercise, and we've talked about some of those that are specific to symptoms too. But we know this is the case, right? And you've heard about some of the physical motor symptoms being improved by exercise. And I'm just going to touch on a couple of bits of evidence to support this cognitive side as well. So if we look at humans 65 to 100 years old, now we're sampling a later in age group, we find that things like attention and executive function, like working memory, are positively correlated with the amount of exercise an individual engages in. That means that more exercise, better attention. More exercise, better executive function. And I'll finish with what I think is probably one of my favorite studies of the last several years here. This is a study that was run by a group in Pittsburgh. Pittsburgh has always been known as a place that does amazing work in neuroscience and movement disorders, in particular experimental work. And what this group did is identified folks who were not exercising. That's actually kind of important for the outcome of this study, okay? And what they said is, we're going to start you on a treatment. They took half of those people and they put them through exercise. This is 3 to 4 days a week, 45 minutes a day, reasonable, moderate exercise that they could perform. Their control group was not people that didn't do anything. In fact, their control group was people that got together, they stretched for the same amount of time at the same place. And then they asked questions at baseline, 6 and 12 months later, about fitness, blood, memory, and they even took brain scans of those individuals. What they found was the exercise group showed improvements. They showed improvements over stretching, and guess where they found it? Not in kicking, but rather in that area where new cells are created, in the hippocampus. Right? So this just a year's worth of exercise changed the size of the hippocampus. Age 67 and higher, that was their group, right? In addition, they show better improvement on cognition, as well as fitness. And guess what? What changed? Our good friend, brain-derived neurotrophic factor. So one of those neurotrophins we wanted, right? How do we get us some, right? Well, here's an answer. Moderate exercise, sufficiently challenging, right? Enough times a week. And along with that comes these improvements in cognition. So sort of in conclusion, and not to get too geeky about it, okay? What we're talking about here are changes, whether it's in physical exercise, and I'm talking about the right side because we're going to be optimistic here, mental stimulation, so cognitive exercise. One thing I didn't talk about today, social interaction, very important, as well as nutrition and diet. All of these things keep our brain in an active state, working as efficiently as possible. As a result, this neuronal activity allows us to increase our expression of neurotrophins, and that maintains the cells in our brains that are important for healthy aging, maintaining our movement as best we can, maintaining our cognition as best we can. So now if we go back to this slide, and we think about what we talked about when it comes to cognitive and physical exercise. Our goal was to move from treatment to prevention. Our strategy is neuroprotection, and we think that exercise is a way to do that. So what about those criteria that I talked about? Is it inexpensive? Exercise is available to us, right? It's accessible. Whether it's trying to go for a walk, having a family member to go to a walk with, going to PT, maybe getting in the pool and doing some exercises. All accessible and inexpensive. Global, we talked about the ways in which neurotrophins are acting within the brain. It's not just happening in one place. And it doesn't have to be a new cell. It can help connect cells and maintain those connections. That's also very important. And then finally, restorative. Well, arguably, this is one of the few ways in which we can stay in those stages for longer. And if we're doing that, I would argue that in addition to adding new cells, we are providing some restoration of function. That's it. Great, okay, first question here. Oh, thank you. Are any of the over-the-counter meds for helping with brain memory function effective for PD folks? None that have been shown to be effective in clinical trials, right? So that would be my answer as a non-MD, which is that there is sometimes evidence that some of these things work, but not enough for them to actually become medications. Are there medications that are not over-the-counter that can be useful? The answer is yes, although I would ask that you talk to your physician about that, because it sort of depends on what symptoms you're personally having trouble with. Gotta keep my glasses on. Exercise doesn't help with the vision, it turns out. All right, what cells in the brains make neurotrophins? That's a wonderful question. And the answer is that a lot of cells in the brain make neurotrophins. Almost all of them use them. However, they're not always turned on. Neurotrophins as a structure are very difficult for our brains to make, so we conserve them. We don't want to use them unless we have to. But when we activate our cells, that's when they get used, because they help the cells to talk to each other, and then they start to connect with each other. Right, so that's the good news. I was talking about things being global, right? Like a strategy, like exercise being global. That means that when you're activating your brain, that's helping them with the connections. All right. Is there a gene in our DNA makeup that can detect Parkinson's? And if so, can it be, oh, this is a wonderful question. Not entirely what we're talking about today, but I said I do different types of things, right? I wear different hats with my different research. So the question is, one of the things that people ask a lot is Parkinson's genetic? right? And the answer is largely no. And it might be surprising to some of you. I would say right now the estimates are between 6 and 15%. And the risk is usually lower for genetic types of Parkinson's disease. There are rare mutations that sometimes can produce it, right? So when we think about the causes of Parkinson's disease, usually, unless you have a very rare form, which chances are none of you do, we don't have a really good idea. We just know what the risk factors are. And you know what the risk factors are, right? It's like pesticides, it's brain damage, it could be any number of the normal things that you've heard about and read about already, right? So that's why Parkinson's is so tricky. It's idiopathic. It means we don't know the source always. And that's very frustrating, right? A lot of what we're trying to do now is find ways to identify it early. That's actually super important. So if there's something right now in the field that I would say is really important, it's that we're using biomarkers to identify it as early as possible so that we can keep you in stage 1 and stage 2 as long as possible, right? That's part of the neuroprotection strategy as well. Figure it out early and keep somebody where they're nearly asymptomatic as possible. All right. Oh, what do I know about focused ultrasound? This is a very interesting, somebody's up on their literature. Whoever asked that one. Okay, this is a relatively new thing. Focused ultrasound is actually a way to target areas of the brain without having to do a super invasive approach. And there's some evidence that by targeting some of the areas that are also being targeted in deep brain stimulation, you can get an alleviation of the symptoms. Now, remember that just like deep brain stimulation, this is not a cure. It's a treatment. It's supposed to reduce symptoms. But I will be keeping an eye on this particular approach moving forward because I do wonder what the next steps or stages are going to be of this approach. Still waiting to get enough data on an approach like this to know how effective it will be or if it will be better than what's currently available.
One thing about that is it can't be reversed.
Well, yeah, that's right. And to be clear, it's really great at targeting something, but when you target it, you're removing those cells from working. In fact, Michael J. Fox does not have deep brain stimulation. He has a surgery which lesioned an area of his brain. It's irreversible. All right, we have questions or recommendations for apps for cognitive training available on your phones, iPads, etc. Oh, I do not have any good ones. Because it's not that they're not out there, just because I haven't looked for them, but I'm gonna have to do that for next time I speak, all right, to find out what apps are actually good. Here are the characteristics that I would look for a good app. I would look for a game or an app that forces you to remember things, because the memory challenge is really important. I would look for those that ask you to maintain attention on something for a longer period of time. And then I would also find one that engages your interests. I know that sounds kind of silly, but something that you're like, oh, I want to learn more about this, or I want to get better at this. If you look for those types of applications, I think you're going to have a better chance of sort of engaging these processes we've been discussing. And if they're not too complicated, that can also help, right? Like, it's hard to, I don't know about you, but like, I can't do stuff on my phone. I feel like an iPad would probably be better, right? Just because you can see it better and you got the buttons. All right. Okay, another good question here. And it goes back to, knowing about Parkinson's disease and lessening your chances of Parkinson's. Somebody asks, can I lessen my chances of PD if my father had Parkinson's? And the answer is, if you are at genetic risk, Okay, so we'll make that assumption based on the question, although we know, of course, that many of the cases are not genetic in nature. It's those things that we talked about that you can engage in now. If you're asymptomatic, my best, I guess, advice would be exercise, keep exercising. You're putting in place the structures that prevent the degeneration so that you've got more reserve. And you might have heard that word before, cognitive reserve, motor reserve. That's something that we're studying in our field right now, is how to create the networks that are resilient enough so that once this thing comes in, whatever it is, we have the network already in place so that we can maintain our function longer, right? That supersedes whether it's genetic, whether it's from pesticides, whatever it happens to be, all right? And let's see, lastly, I've got a couple more. Sorry, I don't want to jump the gun here. Prevagen. Oh, I hear about Prevagen in the morning when I'm exercising down in my basement. It's the same deal with Prevagen, right? Does it help with memory? The idea is that perhaps it may, but it's never actually been studied in clinical trials that have led it to become an FDA-approved strategy for memory, okay? So take that for what it's worth. You know, you can do your own research. My feeling is there are probably going to be advantages and maybe risks to taking something that is safe for consumption, but not FDA-approved for memory function. Oh, yeah, so there was a question about, so there are drugs like memantine and like drugs that are approved. The problem with some of the cognitive drugs that are out there is they only work for a little while, usually 6 to 12 months, and then they tend not to work much, or they have side effects depending upon your experience. Again, not a medical doctor, but having studied some of these things, right, and understanding how they work in the brain, there are some good reasons why drugs like memantine and some of the cholinesterase drugs, whose trade names I don't know, might be useful for some people. All right, those are the same drugs, by the way, that would be used in Alzheimer's disease, and for the same reason in Alzheimer's disease, they're only used for a little while before they stop really working. Let's see. Time, am I good on time? Okay, got 2 more. Nope, done that one already. Okay. Okay, last one. Are there any studies on strong faith making a difference in neuroplasticity? I love that question. And the answer is perhaps. I know you hate the answer, I understand. But to me, if we take faith as a larger part about discipline, right, and engagement, taking time out, quieting oneself, then to me the answer is probably yes. I feel as though anything that's healthy for you is healthy for your brain. And I do believe that people who practice faith are going to have the benefit of engaging their brain in a way that will be positive. Thank you.